kolaborasi dan sinergis. Tidak ada siapa yang lebih jago, siapa yang lebih lemah. There are no overclaim for who is the number one and then who is the number two and etc. But the center is athlete. Also in sport medical team, the physician, the nutritionist, psychologist, and physiotherapy must think about we work together. We are not work in a hierarchy, not like in Indonesian Department of Health, that is doctor is the nakoda. No, the doctor is not a leader. The doctor is the coordination in sport. So every person in sport have same responsibility to be make it center in athlete. This the way to think for us to be a good sport physiotherapy, make it multidisciplinary. So like an umbrella, yeah, we have the two part of the sport medicine do it, injured management and perform enhancement. So when as the injury care management, we have the sport physiotherapy, sport massage, etc. And then also perform enhancement, we must do it the exercise psychology, biomechanics, sport physiology, sport strength and conditioning. Okay. If we don't like somebody who do it our job, please don't do it his or their job. If we must give the exercise for the so don't declaim, so don't claim us is a sport science. No, please, no. If we are a sport physical therapy, we do the sport physical responsibility. We don't we don't like if somebody use the name of sport physical therapy, please we don't use the name of sport science or strength conditioning exercises. If we work in a fitness center and we already have a training for a personal trainer, it's okay. We call it our personal trainer. For me, like example, for me, for myself, I'm a physical therapist. My master in sports science, and also I do it the study in a PhD in sports science. So I can say that I am a sports science because I know about the science. But please, for my friend, my colleague, please don't use the name of sport science if you are not a sport science. If you don't like somebody use name of sport physical therapy, please we don't use the name of sport science. Also massage, okay? We do it together. We do it together in the same way, in the same place. This is the Indonesian problem. Indonesian problem is first, Indonesia physiotherapy is a part of health providers, and a physiotherapy is a part of medicine team. Not every physiotherapist now knowing about this way. Sometimes we feel that we are the hero, we are the number one, we are the Superman, something like that. So we also think that physiotherapy, sport physiotherapy is one of the underbow in Indonesian Physiotherapy Association. So the rule we must follow the rule of health provider in a Kemenkes. Also, we have to know about the physiotherapist position in Kemenkes. So I'm very happy as the directory of sport science. It's a part of sport science. Yes, that's right. But we are not sport science. And sports science is very powerful in Kemenpora. So because of that, and there's a terminology in directory sport science in the world, they make it the sport therapy. It's very overlapping with the sport physiotherapy. Also, we have the internal problem. Yeah, we don't have the guidelines for sport physiotherapy services. That's the problem. So there are not regulation who must to change the name of sport physiotherapy. Now, I want to make it the sport physiotherapist is the member of international in the PFOE. But some of physiotherapists think that it's not necessary. Yes, I understand because we PFOE still cannot give more advantage for the physiotherapist to join sport physiotherapy. So we still increase, we still develop, and then we hope in the next 2 years, every physiotherapist, if want to call sport physiotherapy, is a member of FOE. So all of sports therapy. For example, now I have a problem with physiotherapists in a League One football. They make it their own community. They are not join up a FOE. It's okay, no problem for me. It's no problem for me because if they can maintain the standard, for me it's okay. But please don't make it our sport physiotherapy name bad in the people. Yeah. Always think about how develop yourself. And external, we must physiotherapy, we must show the exercise in the Kemenkes, and we need regulation of sport physiotherapy in Kemenkes and Kemenpora. There are clear terminology about sport physiotherapy and physical activity. Like I said that the sport and physical activity is different in the world. Ya, but Indonesia olahraga, the same is sama olahraga. So the clear terminology, what is a sport and what's the physical activity, and then also we do it the social marketing with the volunteer, like Paralympic. Two weeks ago, that's the one of the social marketing in Asian Games. So like the Muhammadiyah University do it every day. There's the volunteer every tournament. There's a volunteer to be physiotherapy. Don't think about money, but think about experiences. That's more important than just money. Then in general, we must to make it the evidence-based practice guideline for practice. So we have to increase level of education. Indonesia want to make it specialized sport of physiotherapy, and I hope we also can push the asosiasi pendidikan to choose that's a specialized number one is a sport physiotherapist, because actually in a international we need to be a master of sport physiotherapy and also do it the marketing with the volunteer. So don't think about the money, but think about the value. If we give a value, money can come to us anywhere, everywhere. So I just want to say to us, the sport physiotherapy Indonesia,
Ini udah selesai. Kok diem?
mari memberikan bukti. Proof not a promise. So the who is us. So now about what we can do it for Indonesia, especially for sport physiotherapy. Thank you very much for attending my presentation. Assalamualaikum warahmatullahi wabarakatuh.
Recording in progress.
Me.
Okay, thank you very much for Mr. Indra. I will remain again for the participant. If you have any question for Mr. Indra Lesmana, please write on the room chat. Or you can raise hand if you have any question for Mr. Indra Lesmana. I will ask you something. Hello, Mr. Indra. Are you there?
Yes,
Okay.
yes, I still here.
Okay. How to join PFOE? Can you share with us in here?
Pardon, can you repeat the question?
Okay. Please tell us how to join the PFOE.
Okay, how to join the PFOE?
Yeah.
Join the PFOE is just open the pfoe.org or pfoe.member.org. You just give your email address, and then there's the way to register in sport physiotherapy. You must upload your ijazah, and then your certificate in sport, training in sport, and also if you already have the experiences, just write the portfolio, and then we will make it the verification of the data about the physiotherapy, and after that we will give you the card of the member in sport physiotherapy. But also before joining the PFOE, you must follow the basic sport physiotherapist seminar. There, it will be held by the Korwil of the sport physiotherapy, Jakarta, Sumatera, Bali, Sulawesi, Makassar. So after that, so you can join the sport physiotherapy. Also, you can join. Also, you can join in A to Z exercise or level 1 exercise workshop, and then directly to be a member of the sport physiotherapy PFOE.
Oh, okay. Thank you so much for Mr. Indra for explaining how to join PFOA. I have one question again. What's your opinion about collaboration between physio and sports scientists in rehabilitation injuries?
Okay. Like I said before, uh, in rehabilitation is in injury, we cannot be a Superman. We are a collaborator. I have experiences. For example, I just want to talk about my experiences. I'm a sports science. I'm a sports science, so I know about how to give the exercises, doses, and then the right movement for the exercises, and then I give explanation for my physiotherapists who work with me. Uh, because they don't have the lecture when they do the school in the school, so they don't know a lot about the methodic of exercises. methodic, how to make it the doses, how to make it the right movement, how to give it a variation of exercises. Because the injured in a sport sometimes need a long time for recovery, and then it's very make it bored for the patient and the client. And also the athlete with injury, it's difficult to back to the sport because there's the problem of the psychology. And also when there was injured, they can control the intake food, so they will be bigger and bigger. So we cannot give the exercises is like that. This is not good. The psychologist is not good, and the nutrition is not good. Because of that, we need to collaborate with psychologists, with sport nutrition, and also with strength and conditioning trainer or coach in strength and conditioning. So you must make it a collaboration to make it the good result for the rehabilitation. And then when I was work with the sports science, yeah, one of the sports science, it's easy to me to give the exercises. I just say to please give ladder for the agility. Please give cone reel for the speed. So he understand what I mean, and he can give the right exercises for that. That's the different thing about the physiotherapy. But they don't know about injured. So we must control the injured. We must control the exercises. But when do the exercises, we can send to sports science. When we need this psychological approach, we can ask those psychologists to help us. When we need the diet for the athlete, we can ask to the nutritionist. So this collaboration is in rehabilitation, I mean. So it's very, very important. We can do it alone. In my research, it's not finished, but I already have the result of my research. When we want to know about the return to sport test, we are not thinking about the impairment anymore. We must think about the biomotor approach. I want to ask to the audience, how many people know about biomotor approach? I don't. I'm not sure that you know about biomotor approach. That's how to the basic is power, strength, and endurance, and then what is the combination of strength and endurance and something like that. So we need the collaboration for rehabilitation. Actually, not just also for rehabilitation, but for making the athlete have a good result after they're injured. So they will feel safe to return to sport with anything. The injured is clear, the psychology is clear, and everything is clear. That is the most important thing.
Okay, thank you very much. If there is no question again, I will close this session. Thank you very much for Mr. Indra Lesmana for attending and joining with us today. Okay. Waalaikumsalam warahmatullahi wabarakatuh. The next session is commercial break. We will like to appreciate all companies that support our conference, such as PT 6 Warna Indonesia, Visitrack, ProDevice, Total Brace, Kinetics, and PT Satya Abadi Visimap. Now, this is the main agenda for today. It is International Virtual Conference with the first speaker is Professor Dr. Nicholas Budi Parama PhD Specialist Orthopedy with the theme Risk Factor Meniscus Injury in Indonesia Elite Badminton Athlete. The material will deliver through a delay recording, and at the request of the speaker, please refrain from doing a screen capture due to the copyright of the material. Thank you.
Wassalamualaikum warahmatullahi wabarakatuh. Salam sejahtera, selamat pagi. Yang kami hormati Bapak Putro, teman saya Pak Indra Lesmana, Dr. Umi Budi Rahayu, dan Pak Farid Rahmat. Juga yang kami hormati Bapak Suryo Saputra yang telah mengundang saya untuk berbicara pada hari ini. So I was asked to talk on risk factors of meniscus injury in Indonesian elite badminton athlete. This is my disclosure, and currently I'm the chairman of the medical team of Persatuan Bulu Tangkis Seluruh Indonesia. So when we talk on badminton, it's the fastest racket sport that requires aerobic stamina, eligibility, strength, speed, and precision, and a good motor coordinations and complex racket movements. We know that badminton requires the coordinations of various muscles and joints of the body, the upper body such as the neck and the chest, the upper limbs and the core of the body, and the lower limbs. So it is in complex movements and changes in posture variations and rapid directions. And this is often over and over again with sharp and sudden beats, which will lead to a high risk of non-contact injuries to the muscles, the joint, ligaments, and the tendons. If you look at the study from the European group, shows that the risk of badminton injury was about 1.6 to 2.9 injuries per 1,000 hours of play. And the most common is on the body part, is on the knee, due to the eccentric and concentric contractions of the thigh muscles, which is switched rapidly in fact degree of flexions and rotations. So it is cause a large energy loads against the structures in the knee. The flexibility and the strength of the quadriceps and hamstrings muscles that are less adequate, we get various problems in the knee. So the most common injury during the badminton is the meniscus injury. This publication from Sharif shows that majority of the injury sustains that is due to the overuse, especially in the knee, and especially in the younger players, and occurred during the training or practice session. And there's no difference in the incidence and the type of injury between the genders. If you look at the cause of the injury, usually it is lack of experience among the younger players and a more aggressive style of play, and it is cause a high risk of injury. That happens again during the training or practice. The training sessions sometimes involve more injury than producing drills, and sometimes something which the recreational player would rarely undergo. This publication from Rodriguez shows that incidence of injury among the amateur badminton players shows that there's a difference in the incidence of injury according to the player's sex and age, by locations, knee and shoulders the most, and older player, female, and those who dedicate more hours to the training more likely to suffer more of the injury. And so greater experience in the protective factors is very important. How to prevent it is by a good warming up before you play, because correct and sufficient warm-up will be relax and condition of the muscle, and this is adapt to the intensity of the game. Another important point is use an appropriate shoes, because you know that the badminton shoes, you need to damp the shocks and impact to prevent the knee injury. And specific badminton exercises, importance on basic technique, endurance, joint coordination, stretching, and amplifying the muscles. The most common injury on the knee during the badminton players are the menisci. The meniscus is a structure on the knee that serve as a cushion and to absorb the impacts. And the incidence of meniscus injuries can reach to 10 to 34%. So the sudden circular movements at the time of footwork or imperfect landing movement, it will cause a tearing on the menisci. This publication shows that, look at the injury of the badminton in New Zealand, shows again that the knee was the most frequently injured to the multiplanar loading. And we have to remember that the motion in the frontal and transverse planes that may place the knee at a greater risk of injury than movements in the sagittal and plane alone. So they shows here that a non-specific sprain of the knee and the leg are the most, about 32.2%, and followed by sprain of the medial collateral ligament of the knee and acute meniscal tear injury. So now I would like to show you about the anatomy of the menisci. It's a crescent-shaped bearing-like structures made of cartilage that supports the knee joint between the tibia and femur. And it is being the blood supplies from the medial artery and the lateral geniculate, and we divide it in three zones: the red and red, you know, that is the outer part, red and white, and the inner part is white and white. The blood supply of the meniscus determines its healing potential, and about 10 to 25% in adults makes healing difficult. So the structures, it is into the collagen structures, circumferential fibers, radial fibers, and fine superficial layers around the outside. And now if you look at the meniscus functions about the load sharing, is increased area of contact between the femur and the tibia, and decrease the contact stress on cartilage. So if you do a meniscectomy of the medial, the contact area by 50 to 70%, you will increase the contact stress by 100%, while the lateral meniscectomy will decrease contact area by 40 to 50% and will cause the contact stress more than 200 to 300%. However, the functions of the menisci, it increase the concreteness, compensate for the inconductibility between the articulatory surface of the tibia and the femur, the maintaining the stability and prevent the impingements of the joint capsules and synovium when flexions and extensions movements. It functions as a joint lubrications, help distribute synovium fluid, and a shock as a shock absorption and proprioceptions. If we look at the biomechanics at extensions, that 50% of the load is absorbed. At 90% of flexions, more than 90% load sharing, and above 90, the force dominance through posterior horn, as you can see here on this picture. So, means that removing 1/3 of the inner area, the white and white zones, is equal to reducing about 10% of the contact area and increasing about 65% of the contact stresses. Increasing loss of the meniscal tissue will cause an increased contact stress. Medial meniscus root tear can increase the pressure as much as total meniscectomy. And the total meniscectomy increase contact stresses by 2 to 3 times. And now I'm showing about the meniscus tear, that we know that the medial meniscus is stick to the posterior and medial sides and is more fixed and more frequent to have an injury compared to the lateral, which is more mobile and less frequent injuries. It's often occurs in conjunction with the ACL injury. So you have to be aware, or sometimes if you look at the ACL injuries, you have to find whether there is another meniscus, either medial or lateral, being a part of. And about 10 or to 15% of the meniscus tear can be repaired, not all. You see, only 10 to 15%. What tears feel like? If you have a medial meniscus tear, it's more prone to have a mechanical nature. So it's like a flap or a bucket handle configurations. As you can see here, this is a bucket handle. You see there's a loosening of the meniscus, and you will hear the clicking and locking episodes. While the lateral meniscus tear tends to be more radial or horizontal, so it's rapid of the swelling and pain and less mechanical. The question, does it an urgent of surgery? The answer is no. We always try first to the conservative treatments by physical therapy and medications, and if it doesn't help, then we go for arthroscopic surgery. Again, you can see here is one of the best athletes ever in double women. You can see here that acute twisting injury due to impact during the sport, the fixed foot positions, rotations of the knee when the meniscus is pinched, and excessive loads on the knee during the pedestal position. So the history and the symptoms of the meniscus tear, that injury mechanism of twisting injury, you will hear a popping of the knee and the sensation of the knee being stuck or locked, that when half flexions and suddenly cannot fully tighten the knee, this is a sign of a bucket handles. And sometimes you have the phenomenon of clicking. And the symptoms, it will cause some pain, swelling of the knee, and some sensations like the feeling of subluxations or joint like almost loose when you rotate the knee. It cannot bear the load, and sometimes you have a lot of limited range of motion. So how to diagnose it? You can do an X-ray or arthrography, but it is about a decade ago. Nowadays we have more this the benefit of the MRI, which is more sensitive, about 98% accuracy of the medial meniscus and about 90% of the lateral meniscus. And sometimes we have to do an arthroscopic surgery with the accuracy of 97%. The physical examination, number one is pain at the joint line. You see that whether it's the swollen, the joint effusions, and there's reduced the range of motion, whether there's a locking mechanism, catchings, or you sound the popping. So how do they do the test of the meniscus? Special test is you can do a McMurray, as you can see here, and or Apley's compression test, Tesley test, and Steinman's sign. So classification of the tear, what happens when twisting, cutting, pivoting, then you will see that this is the bucket handle tear, you can see here, or the flap tear. This is another sort of the tear. This is a radial tear, or you can have in an older athlete is the degenerative tear. So classifications by shape of tear. I would like to show you one by one. The vertical longitudinal tearing, you will have as many found at a younger age. You can see here the tear. It is more vertical. You can see here. Closely related to ACL tearing, about 90% occurs in the medial meniscus and 83% in the lateral meniscus. And this is on the MRI. You can see that here, a vertical line. You see that here. And that is very easy to find on the T1 and T2 sagittal plane. So how about that horizontal tearing? This tearing occurs on the free edge towards the periphery. Usually it's a degenerative. You can see here. Sometimes it is quite difficult to see, and especially in elderly patients. So if we look at the MRI, you can see here that this continuity a bit here is not all disappear, but you can find it here. So other thing is radial tear, and this is occurred on the free edge but perpendicular to the long axis. As you can see here, this is quite common, and drastically affect the ability to withstand hope stresses. And the deeper the tear, the more it affects the drastic decline in biomechanics. What to see here on the corner plane, you can see here that the radial tear, or on the sagittal plane here, it is quite obvious to see. The latest, the most severe one, as you can see here, this is a tear. It's a vertical longitudinal tear with a flap shift toward the center. This is a bucket handle. It's one of the most type of the tear. Usually double PCL signs, double anterior horn, and absence of the bow. This is very clear. This is the PCL, and you can see here, and there is the bucket handle. You can see here as well. So the last is the parrot beak tear, which is also called the vertical flap. You can see here, the vertical flap. It begins as a radial tear, and the tear continues in the longitudinal directions. This is what you can see on the MRI, or here. So how about the therapy? You can give the options by first non-surgical managements. And if it's failed, then you go further for the surgical management. 3 types of the management you can do is meniscectomy, either partial or full meniscectomy, total meniscectomy, or you can repair the meniscus, or the latest is meniscus transplantation. So in non-surgical, usually when it's stable, longitudinal not more than 10 millimeters with about 3 to 5 millimeters displacements, in degenerative tear accompanied by OA, and radial tearing less than 3 millimeters and stable partial tearing. So how about the non-surgical therapy? You can do as a non-weight bearing, rest, ice packs, elastic band, and the NSAID. Then how about the meniscectomy? The indication, as I showed you before, you can have radial, flap, horizontal, complex. Whether it is the inner part, in the 1/3 inner, it is white to white tear, and the tears that cannot be repaired, such as complex, degenerative, and a radial tear. So it depends on the number of the tear of the meniscus tissue. You can do a partial meniscectomy, as I told you before. The excision is only on loose, unstable fragments. Stable and balanced peripheral rims are maintained. Or you can do a subtotal meniscectomy, and the excisions cover a portions of the meniscal rim. And most of the anterior horn and part of the middle 1/3 are not resected, or total meniscectomy. So the purpose, as you can see here on this, this is the bucket handle, this is the tear, longitudinal tear. The purpose is to clean the tear and maintain a stable edge. Prevention as such much healthier tissue as possible. At about 80% satisfactory functions at 5 years, and the lateral debridement is equal to faster degeneration. You have to look at the alignment. Usually we do when there is a normal alignment, but if there is already varus and valgus, we don't do it anymore. And minimal arthritis and a single fragment tear. So this is the indication for the repair of the meniscus and the relative contraindication. If the tear is more than 1 centimeters and less than 4 centimeters in length, red and red zone tear, so you can compare that with the meniscectomy. It is on the white and white, and while this is red and red. The vertical tear, age is below 40, acute tear less than 6 weeks, and concurrent ACL reconstruction. But of course, there's some relative contraindications such as advanced OA, complex tear, poor tissue quality, and ACL deficiency. This is the way, this is from in to in, then you can see in out, you could put it here, the needle, and then you retract this and you put back on. So, when we talk about the meniscus repair, what does the literature say is that good to excellent sport-specific outcomes and a high return to sport in both recreational and professional athletes. And the problem with the seizure is the capsule exposure and nerve damage, vessel damage. So if you compare about the meniscus repair and the partial meniscectomy, that the reoperations rate after at 4 years, that the repair has more, about 16.5% than the partial meniscectomy. But they claim that the OA on the X-ray that repair about 78% normal, while meniscectomy about only 64%. So how about the meniscus transplantations? Indication is recurrent pain after total or partial debridement, disruptions of daily activities, and age is not more than 50 years. And the contraindication, if, as I told you before, you have a malalignments, laxity, inflammatory arthritis, and advanced OA. So the transplant meniscus replaced of the meniscus can use as by a meniscus allograft, a donor fascia autograft, quadriceps tendons, and patellar, infrapatellar fat pad, and synthetic meniscus. And how about the outcomes? The success rate is vary between the countries. Its long-term benefits are not clear in preventing OA. The partial preservations of the peripheral rims help to prevent the extrusion. So again, risk of playing with a tear. Most of the doctors, they said if there is a tear of the meniscus, you need to be operated as soon as possible. That is not true. Because they said extending the tear possibly requires more tissue to be removed. This is not proven. Worsening arthritis in future, and also this is not proven in the systemic review or meta-analysis. So please note, there are no control studies available to substantiate this. Given this information, what do you do when an athlete is diagnosed with a meniscus tear during the seasons? Ignore it or surgery, and then whether if possible to repair or perform partial meniscectomy. As you can see here, this is after the repair and it is after the partial meniscectomy. According to team physician survey, that 100% have let some play with a tear. You see, 100%. So how quick to return to play following partial meniscectomy is the most is about 2 to 4 weeks, and how quick to returns following repair about 85% is after 3 months, which is more longer than the meniscectomy. And the hardest group to get back following partial meniscectomy is the lateral parts, about 85%. So my approach, if relatively asymptomatic, then try and put off surgery until after seasons. If the symptomatic, you might need recommended surgery. If unrepairable, perform a partial meniscectomy. If repairable, discuss the options with the players, the parents, and the coach. Why? Because you need a longer rehabilitations, more than 3 to 5 months. And the recent therapeutic developments is enhance the healing of menisci with a vascular access channel or synovial abrasions. Arthroscopic repair using a fibrin clot is a question mark, and biologic tissue scaffold and PRP is also still question mark. How about the rehabilitations in meniscus repair? That this publication from the BMG shows that overall 81% patients can return to sports, and the mean of return to sports about 5.6 months. But there are lack of consensus regarding the optional postoperative protocol following the meniscus repair. So this maybe all of you know how to rehabilitate after repair. That is bracing his knee for about 4 to 6 weeks. You walk with crutches and a progressive isometric exercise in cast, and on week 4 to 6, then stop immobilization and start a rehabilitation exercise. And conservative rehabilitation such as strength exercises, flexibility exercises, joint mobilizations, balance and agility, and post-surgical care. This publication from Indonesian Hadi Karyono, the survey on type of injuries in Indonesian recreational badminton players. They show here the acute injuries predominated in age of 21 to 30, about 83%, and 31 to 40, about 53%. And the risk is more likely due to the inadequate warm-up and lack of inappropriate technique. So encourage recreational badminton players to pay more attention to the warm-up process and reduce the risk of injury. And the other publications here shows from the Malaysian Abdul Muttalib shows a survey on the common injuries of recreational badminton players. Again, inadequate warm-up is the most, about 80%, and overplaying about 50%. These publications for comparison of the joint loading in badminton lodging between professional and amateur badminton players, that the amateur players has a greater ankle range of motion and inversion joint movement in the frontal plane, while in contrast that the professional badminton player presented a greater joint momentum in the sagittal and frontal plane, and this will increase the knee ligamentous injury risk. So the risk factors for meniscus tear in elite badminton athlete is lack of warming up, demands for complex movement, different postural variations of lunges, retrievals, reaches and jumps, sudden sharp changes in direction and twisting of the knee, diving for shuttlecock retrieval. My take-home message to have to be considered is that surgery is not necessary when meniscus tear are stable and relatively small and is located in a well-perfused region. This can be treated with a physical therapy. However, surgery is necessary if it affects tear that are unstable and large located on the non-perfused inside of the menisci. Usually, surgeons have to remove the torn part of the meniscus, and this is called a partial meniscectomy. The orthopedic surgeon tries to remove as little as possible so that the meniscus keep its shock absorptions effect. The exercise program should be consist of both concentric and eccentric exercise to retrieve the muscular hypertrophy as well as neuromuscular functions, optimize the neuromuscular coordinations, progress weight bearing and joint stress, and excessive stress force may be disruptive and should be avoided initially. So what I do, when an athlete injured their dominant joint in season, my approach is try to manage non-operatively, attempt an early return to competitions, and can usually tell the patients about 4 to 6 weeks. Acute phase, prefer traditional axonal support by comfort control only, and ASAP, as soon as possible, an active assisted and gentle passive range of motion. One of the most difficult decisions that needs to be made on the sidelines due to the fear of converting a minor to major strain. So the coach decides who play and the doctor decides who doesn't, because you know that Indonesian elite badminton athlete, they are number 1, number 2 in the world. So we have to be very, very careful when we decide what kind of treatment for those athletes. Thank you very much for your attention.
Thank you very much for Mr. Nicholas Budi Parama, PhD Specialist Orthopedy, for sharing us with us today. Okay, the second speaker is Mr. Michael Slowniski with the theme The Future of Telehealth in Indonesia. At this event, represented by Mrs. Obivian Dian Wahyono, a country manager of Physiotherapy Indonesia. Hello, Mrs. Opi, are you there? Okay, good morning. Nice to meet you today. My name is Aura Anissa. I will get you in a 30 minutes ahead. Okay, for shortening the time, dear Mrs. Opi, time is yours.
Thank you so much. First thing first, I would like to say thank you for this opportunity. I'm so sorry for accepting you guys because Mr. Mike is not available here. That's why I'm here on the behalf of him to explain about what is telehealth and then how telehealth can be very helpful for us, especially during our rehabilitation process with the patients. I would like to share my screen. Is my screen now present perfectly? Is now my screen shared perfectly? Is everybody okay with my screen now? Hello, can someone confirm that I can share my screen perfectly?
Yes, Mrs. Ovi, you can continue your presentation.
Awesome, thank you. So, today, on the behalf of Mr. Michael Soniski, he's the General Manager of Physiotherapy and also he's a health operational manager in one of the osteoarthritis institute in the US. He based in Texas, and then that's why he will be 12 hours behind of us, and I'm here to represent him to explain about what is the future of patient's care in advanced technology and mobile apps for musculoskeletal. I would like to begin with a simple questions, and this question is probably for us will answer at the end of this presentations because is the digitalization a future or a beginning for us? And that's why I'm here. I'm Obi. I'm the General Manager for Indonesia and Asia for Physiotherapy, and I also still treating a patients as a physiotherapist in one of the clinic in Jakarta. So that's why I'm here. I would like to put a highlight that I'm here not to tell you what is the best on or what is the things that we should do, but in here we will have a good discussions about what is telehealth and are we able to do the telehealth for us, especially during our practice to help more patients. So that's why Physiotherapy came in. Physiotherapy it's been using for more than 250,000 healthcare practitioners in more than 180 countries all around the world. And we've been using to prescribe an exercise for more than 2 million new patients per year. And we also part of the Apple Mobility Partner since 2016. What does that mean? It means Apple company help us to maintain the apps, and also we are certificated by Apple, but it doesn't mean that Android user cannot use us. Physiotherapy is available for Android users and also iOS users, so everybody can use Physiotherapy. So actually, why we do need to change to the virtual care? Because the needs and the demand changed during COVID. So I'm talking about like back in 2019, when nowadays the payment model also different. In the United States itself, some of insurance pay for the virtual care. It means the patients that got virtual care during the rehabilitations, they can easily to claim the physiotherapies or other treatment part of the rehabilitations to the insurance. And also it makes the regulations and policy change during COVID period, because we still need to give the rehabilitation treatment to the patients, but for some instance, patients cannot come to the clinic, patient cannot come to the hospital because of COVID. That's why the regulations and the policy also change. It's also changed here as well in Indonesia, that now the government also saying yes to the telehealth and telemedicine. That's why nowadays we see many of telemedicine platform, and that makes the patients easier to get a help in the term of to get them to get more like a medicine or also rehabilitation treatment. And why also virtual care become pretty much popular in the US, because it's also the demand, the patient's acceptance, and also they're looking for a virtual care. It really saves their time. That's why it become pretty much popular. And also it's easy for them. They don't have to go out. They don't have to stuck in the traffic. They don't have to spend 1 hour or 2 to just get the rehabilitations through the medical practitioners. I'm seeing to the participants raise the hands. Is that do we need to stop for the questions, or we save the questions at the end? Okay, I think we can just save the questions at the end, shall we? Okay. Miss Moderator, can you help me to confirm my questions? Are we going to stop for a while for the questions, or we save the questions at the end of the presentations?
We can continue the presentation first, and the last is Q&A session.
Just stop me at the end if something wrong with my screen or you cannot see the presentations very well, okay? Okay, and last but not least, why the needs and demand change during the COVID period? Because it's effective. As a health practitioner, we need to make sure that everything we do based on the evidence base. And yes, the virtual care during the post-COVID, it's effective and it's confirmed by some of evidence base that I will show you after this. When everything rushed to the virtual text, that's why some of the evidence base or journal came up to confirm or to make sure whether the rehabilitations suit well to the patients or suit well for the medical practitioner as well. Here's some of the journal that published for some of physiotherapy associations that confirm virtual care really make some change or it's affected during the patient's rehabilitation journey. Here's some of my favorite evidence base that I found pretty much encourage me to use home exercise patients, home exercise program for my patients, for example, because of the effectiveness of internet. That's the journal on the right. That based on this journal, it's pretty much effective of the home exercise program to reduce pain on the patients with the chronic knee pain. So I believe with some of things that we need to check on our list, for example, there's an easy check. Is the virtual care based on the evidence base? Check. So I don't think that we need more excuse or we need more other reason to involve virtual care to be part of our daily practice. I definitely will share my slides and presentations to all the participants, so you guys can have a look and read what kind of journal that also explaining about home exercise program. And if you guys want to know more, please spend some time to read this. It's pretty much interesting to see, and it's interesting to learn about this kind of journal. What about journal about physiotherapy itself? So I would highlight on the very bottom of the sentence that APA Physiotherapy Research Foundations, there's a study back in October 2022 that's showing positive patients and practitioner result. Let's have a look on this slide. This is the summary by the APA Physiotherapy Research Foundations. They put a very nice journal that telehealth by physiotherapists in Australia during the COVID-19 pandemic. This is a very good journal. It is shown that 60% of the patients use telehealth to ease the pain. It means they believe on the telehealth and it causes the pain has been reduced during the virtual care. And then the next questions will appear. What about the elderly, or what about the senior patients? Are they comfortable using telehealth? The answer is yes. 30% of the patients who use telehealth are over 60 years old. I'm pretty much sure the reason why they are more into virtual care, because from the elderly, they get more chance to get other disease if they come to the clinic or the hospital, especially during the pandemic. That's why they are more into the virtual care, that they can access the practitioner everywhere at any time. So this is the 5R future of virtual therapy that I believe this will be our future in our professions. But before we go there, this is the 5 principles that you guys need to ask to yourself before you do the virtual physiotherapy. Number 1, is this the right treatment? For example, you need to ask, is this the right treatment for the patients to do the virtual care? Is it more comfortable for the patients to come because we need to do the manual physiotherapy? Or on this time, the best treatment is not to do the virtual, but patients need to come to see us, and then we can treat them with some of electrotherapy approach that we have. That's one of the questions. Number 2, is it the right time? For example, patients come, they complain about sprained ankle. That's why we need to ask the questions. Is it the right time for the patient to do the virtual, or we need to wait for some of time to make sure the acute phase is gone by giving us such a simple ice therapy, for example, or this is the right time for the patients to do the virtual care with us. Number 3 is the right patients. You need to ask before you do the virtual therapy, is it the patients can be able to do virtual care with us? Is the patients as well having a smartphone or capable to use any of smart device to access camera with us? That's also a question. The next is right clinicians. It means, are we the one who able to do the virtual care for the patients or not? Because remember, virtual care, it doesn't mean only one side, from the practitioner side, but also for the patient side, and also vice versa. It means if we are not able to do this, for example, we don't have enough sources to access the internet, or we don't have enough sources to access the camera, it means for now we are not the right clinicians to do the virtual health or telehealth to the patients. Last but not least is the right payment. Remember, I mentioned that for some of states in the US, some of countries in Europe, and also in Australia, the insurance are able to pay for the virtual care. That's why we need to ask, is this the right payment? Are we charged in a certain and decent price for the patients or not. So this means that things that I want to say, virtual care, telehealth, telemedicines, that's not for every cases, but there's some of things that we need to sort off before we do the virtual care. So please remember these 5 things: right treatment, right time, right patients, right clinicians, and also right payment before you guys do the telehealth or telemedicines or virtual care for your patients. And then when we say, oh, every 5 things are checked, we are ready to use this platform, we are ready to use virtual care or every treatment based on the apps, it means some of point we need to double check. For example, if we want to assign a home exercise program for the patients, we need to make sure we are managing to make a good sets, durations, weights, and also hold. And also we need to make sure the home exercise program, we can easy to monitor for the real time. We doesn't want to lose the moment with the patients. We doesn't want for the patients not be able to reach us. That's why every home exercise program, we need to make sure it can be tracked easily by us and also by the client. And at the end of the day, when we want to assign a home exercise program, it means we want to make sure the long-term goal indicates for a better outcome for the patients. If we don't think or we don't believe that giving a home exercise program doesn't cause anything for the patients, I mean, in the positive things, it will not make a patient even better. It won't ease the patient pain. We don't need to use the home exercise program, okay, for the patients. So thinking about today's webinar, it's talking more about the rehabilitations, the knee approach. Inside Physitrack, there's a lot of exercises that we can prescribe to the patients. And I would like to give one simple example about our library inside Physitrack that contains the meniscus exercise rehabilitations for your client. So this is some of exercise that we have inside Physitrack. If you say, I don't have a time to look those exercises to my patients, I got difficulties to choose exercise the best for the patients, all you need is just go to Physitrack, click template, and then choose the exercise on this folder. On the template, it will be easier for you to choose the exercise that our expert already prescribed, and it comes with a very nice set and duration. So you don't have to think about how many times do I need to prescribe to these patients, how long the patients need to hold on this certain exercise, because everything is there. Already just type the exercise that you want and it will come nicely. You just need to click, choose which one that suits with your patients very well. And then after that, you just need to assign to your patients. For example, this one. This is one of the exercise for the meniscus phase 2 until 3. It comes also with the nice gait walking forward. So I made this exercise for my patients. So I got a patient, he just done with meniscus surgery in Bangkok. He did the physiotherapy here in Jakarta, and also he needs to fly to Australia to have another physiotherapy while he's having holiday in here. So it means I need to make sure my patients do the exercise, because I'm pretty much sure all of you guys will agree that during the rehabilitations, we need to stick on the protocols and we just want to patients keep moving forward. So I need to make sure my patients do the exercise, and also the physiotherapy in Australia, it will make a very nice good partnership because they can help me to monitor my patients as well. So this is one of the exercises that I prescribe to my patients, and I can easy to track my patients whether they do exercise or not. It's very easy to use. So that's one of the sneak peek about library inside Physitrack, and I'm happy to take more questions after that regarding that. So how the flow of the Physitrack journey to the patients? How to use Physitrack to stay connected to the patients? So regarding with the title that I put, the mic put in front, that how telehealth is very useful during the patient's rehabilitations, it's like this. Practitioners, they need to access Physitrack. Meanwhile, the patients, they will use PhysiApp. So don't get confused because I talk about two platforms at the same time. Practitioners, which is us, we are accessing Physitrack. And also the patients, they will access PhysiApp. Physitrack, as I mentioned, is available on every versions, website, iOS, and also Android, and PhysiApp as well. They also, patients can access it through their iOS, Android devices, and also website. So inside Physitrack, you can do the telehealth. You can also prescribe an exercise to your patients, and you can also track the outcome of the patients, and you can easily send the educational content. What is educational content? It's a content with PDF and also video format about the patient's condition. So it's basically the patient's conditions by Google, but they don't have to Google it. We just need to assign a very nice form about patient's condition. For example, my patients got meniscus and they want to know more what is meniscus injury, how did this happen. You just can send this educational content to your patients. It makes all the patients easy to understand about their conditions, and they get more involved during the treatment. So we just need to assign it to the patients because it's very easy, very simple, very secure, and the patients access it. The patient do the exercise and they report to us. So this is the very nice features that we can easy to track our patients' data. We can also know how much pain level that the patients share to us. And also we can do the messaging with the patients. So we don't have to share our personal number because sometimes it's pretty much like confidential to share our phone number to the patients. So with this platform, you can easily do the messaging and also do the telehealth at the same time. So here's a simple telehealth example inside Physitrack. So you can just access to Physitrack, id.physitrack.com, and you do the telehealth with your patients. You don't have to install anything. Just need to open your account, and you can easily to connect with your patients. During the sessions, you'll be easy to share your screen and also to do the streaming exercise. So this means you'll be able to check whether your patients do the exercise or do their movement right or not. Then also you can do the exercise together with the patients. So again, all the patients need to just internet connections that the patients can follow the exercise, and you can also monitor whether the patients do the exercise right or not. And for easily, you can do or activate the goniometer. I feel like this feature is pretty much very functional because I can track my patient's range of movement when they are not be able to come to the clinic. And it makes sure that we are creating more data to the patients. So whenever the patients want to know what is my progress, I can easily share this data because I can use the goniometer with my patients. That's about it. That's all about Physitrack. And if you guys have any questions, you can raise your hands or contact me to WhatsApp or just email me. And if you guys want to know more about Physitrack, just go to id.physitrack.com and you can try the demo. The demo it's free and it's easy. You can just playing around, seeing what's inside Physitrack, because we do have more than 15,000 exercises inside the Physitrack. Thank you.
Okay, the next session is Q&A session. Pardon, Miss Opie, there is one participant that clicked their raise hand. Let me invite Miss Alisa to asking the question directly to Miss Opie. Okay, for Miss Alisa, time is yours. Hello, Miss Alisa. Okay. I will ask you about how to register or make account at Physitrack. Can you explain to us, Miss Opie?
Definitely. That's a very good question. I'm sorry to skip on that part because I'm afraid we don't have enough time, but let me just show you how to, for example, create an there will be a nice drop prize after this, if I'm not mistaken, whether it's already announced or not, that for the one who how is it, like for the journal or something, you guys have the Olympic journal or something. For the first winner, you guys will get a free account of Physitrack for a month. So that will be exciting to use. Okay, so this is Physitrack. This is the demo versions. You can just take a look on those kind of exercises. We do have more than 15,000 exercises in here. And the price to subscribe Physitrack is from 114,000 per month. And you just need to start your 30-day free trial or create a new account. And then just follow the instructions. Put your first name and the last name, your work email, and create an account. So it's super easy. And if you still a bit confused and you want to know more about Physitrack, please do not hesitate to just reach me on my number, WhatsApp number, or my email. This one, or d@physitrack.com. Yes, just go to id.physitrack.com. I'll put the link on the chat as well. And like you say yourself.
Okay, thank you very much for Mrs. Ovivian. Thank you very much for Mrs. Ovivian for giving us such informative and interesting presentation today. Okay, see you again at the next season.
Thank you.
Okay, see you. Okay, the third speaker is Dr. Asep Santoso, specialist orthopedy, with the theme arthroscopic surgical treatment for meniscus injury. Hello, good morning, Dr. Asep. Nice to meet you. Yes, it sounds so clearly. Okay, today we will learn about arthroscopic surgical treatment for meniscus injury with you. Okay, before Dr. Asep doing his presentation, I'll remind for all participants, if you have any question for Dr. Asep, Feel free to put your question in Q&A box below. Okay, for certain the time for Dr. Asep, time is yours.
Okay, thank you very much for the moderator for the introduction. Can you see my slide? Hello?
Hello? Yes, I can, Mr.
Yes,
Sir.
okay. So I may start. So thank you very much. First of all, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. First, I would like to thank to the Committee of Academic Physiotherapy Conference of Universitas Muhammadiyah Surakarta for this opportunity to share my experience about treating meniscus injury by arthroscopic surgical treatment. So as we know that a meniscus injury is actually the full prevalence is around 10% in an asymptomatic knee. So it is not always symptomatic, the meniscus injury. So even in on MRI, we can find around 27% of meniscus pathology in an asymptomatic knee. And the meniscus injury is more common occur in non-pivoting sports compared to the pivoting sports. For example, a runner will have a more chance to have a meniscus injury compared to like a football or basketball. Yeah. And this is the interesting data that most of meniscus tear is occur in an ACL injury, which is the incidence is 57 to 80% of the case. This is if we see the data, how the various sports will have a risk of meniscal injury. We may see here the highest number of meniscus injury rate is in athletic, yeah, running, but the smaller number will presentation will in basketball, even in football they have only 14% of the case, yeah, even smaller also in other like handball, yeah. So athletic higher number, yeah, and then we have basketball still high, yeah, for the meniscus injury. So this is how we the semantic of the meniscus, yeah. We have medial meniscus and the lateral meniscus, which is a C-shaped fibrocartilaginous structure lying between the femoral condyle and the tibial plateau. The meniscus works as a shock absorber, facilitating weight bearing, and also it have some role on overall stability of the knee joint. We can divide meniscus into several zones: the posterior, the anterior zone, and also the pars intermedia. We can also divide the meniscus into the zero. Zero is a capsule, actually, the capsular attachment. Number one zone is a red zone, which is have a higher vascularization, red-white zone, and also white-white zone. Yeah, the less vascularization of the meniscus. So this is how we see the function of meniscus. Yeah. This is when the meniscus is present, see that the peak contact pressure on the knee joint is almost equal all around the surface of the knee joint. But if we remove the meniscus, then we see this graphic that the peak contact pressure will be very high, and it is very dangerous. That's why meniscus is very important in the knee joint. So this is when we see the meniscus is unfunctioned, then the peak pressure and injury to the cartilage will happen, and cartilage damage will happen also, actually. This is the meniscus pathology, the meniscus biology. See, the collagen fiber ultrastructure of the meniscus is very complex, even in the surface and the inside structure of the meniscus. And this is when we compare the vascular density, the vascularization between the red zone, red-white zone, and white-white zone. We see here in the white-white zone, almost no vascularization. It means almost very difficult to heal, even if we do repair in this zone. Yeah, so it will make decision making. It will have a role on decision making of the treatment of the meniscus. This is one new paper from American Journal of Sports Medicine 2021 about the evaluation of age-related change in the microvascular density in the human meniscus. So if you see here that the overall vascular density is decreased with increasing age. So with the age, older patient will have less vascularization in their meniscus. And it said that also the conclusion is that no facial formation were detected in the red-white and wet-white zone after adolescence. So after adolescence, no new vascular in the red, white, and white zone. It is very important information for us, a surgeon. So what is the definition of meniscus tear? This is the European Meniscus Consensus Group from ESCA, European Society of Sport Traumatology, Knee Surgery and Arthroscopy. They said a meniscus tear is a traumatic meniscus injury which is associated with sufficient or a significant injury, and the patient has a sudden onset of knee pain. Whereas the meniscus lesion is a degenerative meniscus tear marked by slow progression of pain. Usually the patient has no an acute pain, that just slowly pain. That is what we mean as a meniscus lesion. This is how we see a normal meniscus inside the arthroscopy. See here, this is a picture. Yeah, we see the meniscus inside. Just the upper part is the condyle femur. This part here is a tibial plateau. So it's lie between the femur and the tibia. Work as a shock absorber. And the spectrum of meniscus pathology, it will from intrasubstance. Yeah, intrasubstance. This is the example of intrasubstance injury. Yeah, see here on the lateral meniscus there is intrasubstance. The color is white inside the meniscus. This is the intrasubstance. Usually we do nothing, yeah, to this patient. We do just a conservative treatment. Another thing is that there is a free edge irregularities. There is a tear, of course. Also that there is a secondary lesion, like in this figure. This is MRI of meniscal keys. This is a secondary lesion of the meniscus. How we classify the meniscus injury? International Society of Knee Arthroscopy and Sport Medicine have classified the meniscus based on the depth, based on the location, based on the severity of the tear, and also the length of the tear. So based on this zone also, but for us, simply, we can see that meniscus can be seen as a longitudinal tear, just like this, the radial tear, or a flap tear, or a horizontal tear. This is like in the longitudinal tear, we may classify into small tear, small longitudinal, large longitudinal, and a bucket handle, which is displace of the meniscus structure. So we will talk about the surgical management of meniscus injury. The meniscus, so surgical treatment for meniscus is ranged from a repair, yeah, we save the meniscus transplantation with an use of allograft from another patient or cadaveric. There is a meniscus replacement with synthetic graft. And also the last is, of course, there is a meniscectomy, whether it is total or a partial meniscectomy. But the hashtag for us is still, we will always try to save the meniscus, yeah, because we know the function is very important to preserve the joint, to prevent it from the osteoarthritic changes. This is the technique, just sharing. It's nice to know for you about the technique of meniscus repair. We have an inside-out technique, outside-in, all inside technique, or even the transtibial pull-out. This is very technical. This is for orthopedic surgeon actually. And we start with a discussion with several types of meniscus injury. This is what we call a bucket handle tear. Bucket handle tear is actually a longitudinal tear of a meniscus, yeah, or large longitudinal. It occurs in around 38% of the cases, and have a very high failure rate. This is what we see. This is one of our case. This is what we see, a bucket handle meniscus tear on arthroscopy. See that the part of the meniscus is displaced from its anatomical position. So this is the condyle femur. In this video, we try to reduce the meniscus to its anatomical position. We may see this video. We try to push the meniscus back to its anatomical position. So this situation actually very painful for the patient, and also there is locking. That's why you need to ask the patient, do you have any sensation of locking or clicking or any painful? This is, if the patient said there is a locking, maybe this is the situation. This is a displaced or a bucket handle tear. Yeah, this is when we finish reducing the meniscus to its anatomical position, and then after that we are ready to repair the meniscus to its position. Bucket handle. This is a case of male 22 years old with ACL tear. See the complete tear of the ACL almost gone, the ACL. And this is the video of another case with, the video of this case on the medial meniscus bucket handle tear. Yeah, after we reduce, we do repair with suture, and this is when we finish the ACL reconstruction, and also we finish the meniscus repair. We may see here the meniscus has been reduced to its anatomical position and has been repaired. This is the bucket handle meniscus tear. This is, we have one very interesting case. When we found both medial and lateral bucket handle meniscus tears, we see this figure. This is the figure from arthroscopy. This is the ACL remnant. This structure is actually a displaced medial meniscus bucket handle, and this structure is the displaced the lateral bucket handle. This is a very rare case, and on MRI we seen this figure, the double pitch L sign. This is specific sign on MRI. So such a rare case. So this is the figure, number 1, 2, 3. Number 1 is a medial meniscus displaced. 2 is for the ACL. 3 is for the lateral meniscus, which is displaced. The figure B is when we reduce and repair the medial meniscus, and see the lateral meniscus still displaced. And after that, we finishing repair the meniscus, and this is when we finish the ACL reconstruction and both repair to the medial and lateral meniscus. Next, we talk about radial tear. What is radial tear? This is something different and something difficult situation for a patient. The radial tear is actually not so common, around 7 to 18% of case of ACL injury. It is a difficult to treat situation, and the result is that very difficult. Also, there are only 57% rate of partial healing. So the healing rate also poor. Yeah, this is the schematic of figure how we see a radial tear of this of the radial meniscus tear. There is a small, large, even a complex radial tear. This is one example of radial meniscus tear with cartilage damage. Yeah, see here the MRI. This is the radial meniscus tear and the cartilage damage. This is the video showed when we try to reduce the meniscus back to its position. Yeah. See, you may notice that the meniscus is actually displaced radially outside the joint. And this is when we have been, the meniscus have been repaired with the use of all inside technique. Yeah, see the video, we repair the meniscus, yeah, but unfortunately the patient has already a damage cartilage of the knee joint because he's coming late, yeah, after the injury. This is the situation. You see the radial meniscus is already, there is an extrusion of the meniscus. So the meniscus is actually gone, displaced outside the joint. So the function is already gone, then the damage of cartilage will happen in the radial meniscus tear. Another thing is the meniscus root tear. So there are so many types of meniscus tear. This is one of them, meniscus root tear. This is the root when the meniscus attached to its bony attachment on the tibia. Yeah, there are so many classification here, and the prevalence is around 9.1% of the overall injury. Yeah, if there is a the meniscus root tear, there is an increase of the contact pressure. That's why repair of the meniscus root tear is very important, because it's also associated with meniscal extrusion. This is one of our case with a lateral meniscus root tear. We see here that the meniscus is detached from its bony attachment. Then what we want to do is we try to get it back to the tibial plateau, just like this figure. With the use of this kind of device, we suture, we make a knot on the meniscus, and we make a tunnel on the tibia. Okay, you can see here, we drill, we make a tunnel on the tibia, and then we pull this the meniscus like this. Yeah, this is the, yes, this is the last picture after the this is the last picture after we completely repair the meniscus. We get it back, the meniscus, to its anatomical position. Then we wait for the meniscus to heal. What is meniscus extrusion? This is very important situation. Usually the pain will come with a very painful, yes, of the knee joint. Meniscus extrusion is when the meniscus is displaced outside the joint, just like this figure. Yeah, you may see here. This is the normal meniscus, and this is the meniscus when it's displaced outside the joint. And this the axial view also the same. You see the meniscus is displayed. So actually, almost no function. The meniscus is there, but have no function. So we need to reduce the meniscus to its anatomical position. It's usually occur in the meniscus root tear and radial tear. So this is actually a nightmare for a patient when they have a meniscus root and radial tear, because so many implications for them. This is the situation. This is on MRI how we see the meniscus on MRI. Yeah, the meniscus extrusion just already displaced outside the joint. This is the study showed that the meniscus extrusion has a high chance for osteoarthritic changes. Yeah, the extrusion meniscus will have a severe osteoarthritic changes. Okay, now we move to the horizontal tear. What is horizontal tear of the meniscus? Yeah, see the figure here. The meniscus is actually divided into its upper portion and the lower portion. Yeah, the superior cleft and the inferior cleft. So it's accounting around 30% of the case. Historically, the surgeon will do partial meniscectomy, but we know that if we remove the leaflet, that there will be a high peak contact pressure, and also there will be risk for osteoarthritis. That's why for horizontal meniscus tear, also the recommended treatment is we need to do repair of the meniscus. This is one of our case, yeah, a male 26 years old with ACL tear and lateral meniscus horizontal tear. We may see here on MRI there is a white line inside the meniscus, and this is the horizontal meniscus tear. And when we see on arthroscopy, see on video is clearly show that the meniscus is divided into its upper portion and the lower portion. So we need to do repair. We need to make it in one portion again. Yeah, so we do repair. This is after we repair the meniscus to in grid attachment. So we may hope for healing of the meniscus, and we'll make it in one portion again. So next is discoid meniscus. What is this discoid meniscus? This is quite common actually. In the United States, the discoid meniscus the incidence is only 3 to 5%, but in Asian population it's up to 15%, quite common. Not all patient is symptomatic, but some of them are asymptomatic. Yeah, so discoid meniscus also has a high chance for rupture, which is up to 72% of the case. So this is how we see the figure of discoid meniscus. You may compare the discoid meniscus. Discoid is actually the meniscus is covering all the tibia plateau. Yeah, but the normal meniscus actually in C shape. So that is the difference between discoid and the normal meniscus. This is a congenital abnormality actually. This is when the discoid meniscus is torn, A, B, C. This is one of our publication about discoid meniscus. We have several case experience in discoid meniscus. Most of them are female gender. Most of them also a discoid lateral, not medial meniscus. Most of them is a complete type of discoid meniscus covering all the tibial surface of the joint. And some of them also has a rupture, and we do repair. This is the case example of discoid lateral meniscus. This is a male, 18 years old, with complaint of clicking and painful of the knee during extension, usually during extension. You may see here, the medial meniscus here, there is a triangle shape. This is a normal meniscus. But compared to the lateral side, the meniscus is flat and wide, and covering all the tibial surface. So this is a discoid meniscus. We diagnose it preoperatively using an MRI. And then when we see on arthroscopy, this is what we see inside the arthroscopy. See that the meniscus is covering all the bone. And after surgery, we do surgery to meniscus to reshape the meniscus to its just like normal anatomy, the C shape, and we make it into a C shape. So the contact pressure of the cartilage will meet the cartilage, and there is a good distribution of the contact pressure of the knee joint. This is another case of male 28 years old with ruptured discoid lateral meniscus. We see the figure here, the lateral meniscus discoid is covering all the tibia, and this is the video showing the discoid lateral meniscus with its ruptured portion. Okay, this is the ruptured portion at the anterior. The attachment is already ruptured, so that we do repair of the meniscus, and then we do reshaping of the meniscus, discoid meniscus into its normal anatomy. Sometimes also we made a complex tear. Complex tear means a combination. There is a flap, there is a longitudinal, there is a radial tear also in same meniscus. So in that kind of meniscus injury, usually chronic meniscus injury, we always try to repair, but if it is possible, we may do just a meniscectomy like in this case. We remove this flap, so the patient will reduce their symptoms of pain. Usually because this flap, the patient will have a painful knee during the motion. How are the outcome of the treatment? Do we have always good outcome after a meniscus repair? You know, meniscus repair is actually more challenging than the ligament reconstruction itself. Usually we do ACL reconstruction in just 30 minutes or 45 minutes, but repairing the meniscus is somehow we need more time, usually 1 hour or more. But so that's why meniscus repair is more challenging actually than the ACL reconstruction itself. So we see the literature. How are the outcome of meniscectomy? We try first with meniscectomy. This study is 2021 from the Knee Journal from British Society of Sport Medicine. They evaluate 225 patients. They still conclude that arthroscopic meniscectomy should be avoided because it have a high failure rate, and the conversion rate to TKA is around 4%. Another systematic review from the recent year 2022 from the Archive of Orthopedic and Trauma Surgery, they found in a follow-up 7 years follow-up, they found a good long-term outcome for a meniscus repair. Yeah, and it's proof with its effect on chondroprotective for the knee joint. This is another systematic review from KSSTA 2022. They said the overall failure rate of meniscus repair is 19%. Actually, it is quite high. But it remains unclear whether the failure rate is come from the repair itself or new additional tear. So still in debate. But of course, because there is a quite high overall failure rate of meniscus repair, this is a challenge for us as an orthopedic surgeon. So what if we compare the meniscectomy and repair? Yeah, this is a systematic review from 7 studies with 367 subjects. They found that meniscus repair have a higher reoperation rate than the meniscectomy, but the meniscus repair more likely to result a better long-term patient-reported outcome and better activity level. That's why even the failure rate is high, we may still try to save the meniscus. We will always try to save the meniscus by doing repair of the meniscus. This is one of the example. This is credit for our partner in physiotherapy, IBS Physiotherapy in Solo. This is one of my case. ACL reconstruction, and medial meniscus bucket handle tear, and now the patient can play football again. Oh, sorry, the video is cannot working. Okay, no problem. This is case with medial meniscus bucket handle tear and ACL reconstruction. Another case, do you remember this wonderful lady? Yeah, the Indonesian Paralympic gold medalist in Tokyo 2020. Actually, she had been diagnosed in a meniscus tear, yeah, partial meniscus tear. But then we decided to do conservative treatment to this patient, and finally she got 2 golds and 1 silver medal in the Paralympic gold medalist. And of course, we thank to this wonderful guy, Mr. Suryo Saputra Perdana, as the man behind the champion. Thank you very much for your support to us. So thank you very much. This is the end of my lecture. Thank you.
Okay, thank you very much for Dr. Asep. Okay, the next session is Q&A session. There is two questions from the anonymous attendee to Dr. Asep. Do you want to type the answer or answer the question directly?
Directly.
Okay. The first question is, how long the recovery phase longitudinal tear? Is it quite different from horizontal tear? Okay. Time is yours, Dr. Asep.
Okay, thank you very much for the question. The time for recovery of longitudinal and the horizontal tear, yeah. Actually, it is of course depend on the severity of the case, yeah. Whether the longitudinal tear is a long or large tear, or horizontal tear also, large tear or small tear, yeah. Usually the both longitudinal tear and horizontal tear will have tear on red-white and red-red zone. So that's why during the repair of the horizontal tear, we will remove the white-white zone, and we still left the red-white and red-red zone. So actually both of them has almost the same rate of healing, yeah. Usually we will wait the patient for around 6 weeks for non-weight bearing, because you know the soft tissue healing actually is 6 weeks. But after that, we may start after 6 weeks. The patient, we may start to start weight bearing, and usually we may start to back to the sport is after 6 months. So actually between the horizontal and longitudinal is almost the same. That's my answer. Hello.
Okay, thank you very much for Dr. Asep. We can continue to the question number two. As a physiotherapy, I found signs of locking at my patient. Do you think that was precise sign from meniscus? Or is there any other symptoms of meniscus during surgery?
Locking. It's about locking. Okay. If we see, okay, locking at my knee patient. That was precise sign for meniscus. Okay. Yeah, about locking, the locking complaint of the knee. You know, locking of the knee is not 100% due to meniscus. There are many reasons of locking. Usually there is a cartilage lesion, for example. There is a loose body of the cartilage. There is loose body of the bone. It can also make locking. Yeah. So from physical examination, okay, this is a sensitive sign for the possible. We may say that this is possible meniscus tear, but still we need to confirm it with a more advanced examination like X-ray or MRI. So it is quite important to see the locking, but it's not always for meniscus injury. So that's why when the patient come to me, I will always ask the patient to do MRI because we need to have exact cause of the locking knee. So another thing about the surgery, actually during the surgery, no sign, no additional sign on the meniscus, but we can see directly, we can evaluate all part of the meniscus in anterior, posterior, even the very back side of the posterior we can see during the MRI. So there is no additional sign on surgery. Thank you. Is there any other question?
Okay, there is no other question. So I can close this session. Thank you very much for Dr. Asep Santoso for sharing with us today. See you at the next session. Goodbye.
Thank you. Bye-bye.
Thank you very much. Okay, for the fourth speaker is Assistant Professor Kamsak Suri, PhD with the same research translation of meniscus study to physical therapy practice. Hello, good morning. Achan Kamsak Suri. Hi. Okay. At this session is different from the previous session. At this session, we have two speakers from different perspective. Assistant Professor Kamsak Simsurin will discuss about physical therapy and meniscus. And the Dr. Muri is discuss about sports nutrition to increase exercise performance. I think that will be the great collaboration with physical therapy and nutrition. Okay. Before Mr. Kamsak Simsurin start the presentation, I'll remind you all participants, if you have any question for Mr. Kamsak Simsurin, please put your question in Q&A box. Okay. To shorten the time, dear Mr. Kamsak Simsurin, can we start now?
Yes, thank you.
Okay,
Thank you
time
very
is yours.
much, moderator.
Mr. Kamsak Simsurin.
Yep, can you hear me clearly? So hopefully my voice is clearly. So hello everyone. So first of all, I would like to say thank you very much for the host of this kind of conference. So for the physical therapy. So my talking today, so I'm going to focus on the research translations of meniscus study to physical therapy practice. So hopefully the benefits or my talking today would be benefit for physical therapy to apply to your clinics. Okay. So my content is broadly divided into parts. So the first one I'm going to focus on the review, and the second one, so I'm going to provide a key message or key suggestion for physical therapy to apply in your clinical practice. But for the review part, so mostly I'm going to focus on the post-operative rehabilitation after meniscal repair. As the previous speaker already mentioned that after meniscal injury, mostly they try to preserve the meniscus for doing their function in the future. If it would be the first choice, as the previous speaker mentioned, that to prevent the complication in the future. Okay, so let's start the post-operative rehabilitation after meniscus repair. So from review the rehabilitation with early weight bearing and range of motion after meniscal repairs is quite varied. Some study they reported that the weight bearing exercise and the knee range of motion exercise will be around take part after surgery within 3 days. But some study reported that they propose or they prefer the patient to take the weight bearing and also the range of motion exercise after surgery within 4 to 6 weeks. So you can see that is quite very vary of the rehabilitation in nowadays, and also, but mostly the research, they try to explore or try to study the effectiveness of the rehabilitation, and they like try to separate to see the effectiveness and comparing between the loading progression exercise and also the weight bearing restriction. So, but however, nowadays, there is no consensus exists for a standardized post-operative rehabilitation strategies after meniscal repair. So in the future, we still need more research of rehabilitation in specific conditions, as well as the ex-speaker already mentioned that there are various types of meniscal injury, you know, and I'm gonna mention later that why it's still like we still cannot have like a consensus or standardized rehabilitation program. So there are many factors that involving for the meniscal repair, and we should consider about it. Okay. As this is the figure to demonstrate the different types of meniscal studies. So this is the figure for the physical therapy to more understanding about the type of injury. So different type of injury is mean, and also it means different location or the intervention outcomes. For instance, if the injury is occur in the red zone compared with the white zone, the outcome would be different as well. This is the one point that physical therapy should concerns about this, you know. So, but however, the outcome of rehabilitation outcome and also the return to play time and performance after surgery, it depends on the first one, the surgery technique, and the second one is the post-operative rehabilitation after surgery. But anyway, the goal of rehabilitation, our goal is to protect the surgical repair while also balancing the cost of immobilized and disuse, you know. So this one, the physical therapy very concerned about this. If we care about this, because as we have known that in the long term of immobilization and also the disuse, it would create some complications such as the strength, poor muscle strength, right? And poor neuromuscular control. So this one, we don't want to have it after surgery. So that's why rehabilitation study try to promote or try to propose the accelerated rehabilitation. So I'm gonna tell you what is the accelerated rehabilitation. They try to compare the accelerated rehabilitation to the conservative treatment, and we're going to see the result, and we would get some idea for applying the clinical practice. But however, in the accelerated rehabilitation, the rehab, we concerns about the range of motion exercise and also the early weight bearing exercise. So because with the concept of early intervention, we try to promote the healing process with optimal loading. So that's why this kind of concept is quite getting more popular and also getting used to in the physical therapy clinical field. But nowadays the research still cannot summarize yet, but I'm going to present to you what is the result comparing between accelerated rehabilitation program compared to the conservative treatment program. Because in the research, they try to study and see the effects of the accelerated. It's gonna promote in the positive way, or it its effect on the negative way. Okay, this is the study they reviewed and reported the rehabilitation comparing with and without immediate weight bearing in 2012. So this kind of study report and review in a study of meniscal repair using the fast T fixed device. This is the surgical technique after meniscal injury. So they study and they found that there are the two rehab programs that they focusing on. The first one, conservative rehabilitation, and the second one is accelerated rehab program. So for the conservative, they promote the non-weight bearing for 4 to 6 weeks. So this is the mean average of non-weight bearing in the conservative intervention idea. But for the accelerated rehab program, they promote the immediate full weight bearing as tolerated. So that means if the patient ready and therapy think, okay, this guy is ready to exercise and to start to take the weight bearing. So the study promote the weight bearing as tolerated individually. And they found that the clinical outcome or in terms of the repair failure for the accelerated, they found 13%, but for the conservative treatment, they found 10%. So that means compared to study, no notable different. It seems like the number of repair failure is pretty similar. 10 and 13% is not a big deal or big difference. Okay, but in 2015, this also revealed many studies in the previous, and also they analyze the data and compare between conservative and accelerated program. But in this one, they focus on the successful clinical outcome as the parameter of the review study. So for the conservative rehab program, they still focus on non-weight bearing, but the mean time of the study, the range of the non-weight bearing is start from like 2 to 4 to 6 weeks. But for the accelerated rehab program, they still maintain the concept as the immediate weight bearing as tolerated as well. So the clinical outcome, they observe the successful clinical outcomes, and for the conservative treatment, they found 70 to 94%. But for the accelerated program, they found 64 to 96% of the clinical outcome. For the clinical outcomes, the previous study or the research, they proposed using the List Home score and technical score for assess the outcome measurement. So that means in terms of the successful clinical outcome, this kind of number is also the big deal or not big difference. That's so. In other way, we can interpret it as that the accelerated program may not create the negative effects if the therapy promotes the accelerated program in the meniscal repair. But however, let's mark on your mind that this kind of study, there are many types of medical injury in this study. Please mark on your mind. It's not isolated one type of the injury, so we need to think about this as well. But however, this kind of research guide a little bit as that accelerated program may not create the negative effect in terms of the long term, especially in the repair failure and also the successful clinical outcomes. So, but however, as I mentioned, there are many types of injury in the previous study. But in 2017, this guy reviewed and selected the study to compare the results, but only focus on isolated meniscal repair. So that means exclude any study that the patient show more than one injury, like more than one meniscal injury. Okay, because of the exercise program or the weight bearing, also it's described as the physical stress intervention to loading on the tissue that may affect the rate of healing tissue. That's why the research try to continue to see the effects of weight bearing and also the range of motion exercise. So from the study, they divided in 4 groups. So the first group is the accelerated rehabilitation. So the study allow immediate motion exercise greater than 90 degree of flexion and also weight bearing as tolerated. And the second group, it is the rehab with motion restriction. So they limit the motion exercise less than 90 degrees, but anyway, they allow the patient take weight bearing as tolerated. But for the third group, the rehab with weight restriction. So that means they allow to immediate motion exercise 0 to 90 degrees and allow, but weight bearing was limited. But for the fourth group, the restriction in both knee range of motion exercise and also the weight bearing exercise. So let's see the results of 4 group comparison between accelerated, we have with motion restriction, we have with weight restriction, and also the fourth one, restriction in both motion and also the weight bearing restriction. So this is the result that I draw to the study. So for the rehab program or accelerated rehab group, they found 2 studies. And 2 study for the rehab with motion and for the weight restriction, and 9 study for the restriction in both motion and weight bearing. And so you can see that the clinical outcome, this is the time related with the time recovery. So they mark about the running time that allow for the patient to start. So you can see that for the first group, there's the patient can start to have the running activity in 8 weeks, but for the motion restriction, there is no data. And for the weight restriction and also the dual restriction, it starts at the 12 weeks. That means 3 months after surgery. But for in terms of sport participation, so you can see that weight bearing group here it can start at 12 weeks, but for weight restriction is quite varied. The mean of weight restriction can start the sport activity at 12 to 24 weeks, and the dual restriction it starts at the 16 to 24 weeks after surgery. But how about the success rate? They found that for the success rate, for the first group, it's ranged from 72 to 100. For the second, 73 to 100%. And the third group, weight restriction, the success rate, it is the 62 to 83%. And for dual restriction rehab, the successful rate is 25 to 100%. So that means when I look at this data, so it seems like an accelerated program or accelerated rehab. It's the success rate is not different with the conservative treatment. But however, I think this time recovery time for joining any activity is pretty show superior, a little bit superior data here. So that means maybe the accelerated rehab program may helping to avoid some of detrimental effects stemming from periods of prolonged immobilization. As I mentioned before, prolonged immobilization, it would create the complication later, such as poor strength and also poor muscle volume deficit. So we don't want to have this in our athlete or our patient. So this one may affect the function and return to play time. Okay. So how about and more than that, in 2018, they proposed and they mentioned and they suggest that accelerated rehab for specific injury, especially the vertical tear, does not result in a higher failure rate than conservative rehab. So this study proposed that it may be appropriate to allow weight bearing as tolerated follow meniscal repair of peripheral or vertical tear, as we know that if it's occur in rate. So as we have, as the ex-speaker already mentioned, that if the injury size or injury location is located on pretty in the red zone or vascularization, so the healing process might be pretty good prognosis. So as I present to you, in many studies, there are many factors or many limitations between when we compare between study. So that means when we read through the article or when we think about how will we prescribe the exercise for our patient, we need to concern or we need to think about the many factors between study. So including the meniscal tear patterns, is that the same as the study that we're going to apply in our patient, the fixation techniques and the level of patient compliance, how our athlete or how our patients stick on the exercise or rehabilitation program, and how about the rate of progression through the phase of rehabilitation, how the access to formal physical therapy from the primary literature. So this quite different between studies. So when we interpret the result, we need to think about this as well. More than that, other confounding factor when we read through the meniscal repair study, we need to think about the age, patient or athlete age in each study, and also the location of tear, as I mentioned. Okay, so the next, this is next is the key suggestion to the clinical practice. So as I mentioned, when we think about or when we interpret the science or the evidence in clinical practice, comparing between accelerated and conservative treatment, the result or success rate or failure rate is not different between accelerated and conservative. But however, so our clinical practice still based on the science or the evidence. So in the previous other side, they proposed that the mobilization after meniscal repair in animal models promote blood flow. We expect why we prescribe the mobilization or the range of motion exercise in early intervention concept, because we would like to promote the blood flow or the vascular in the injured side. And also the basic science clinical research study have confirmed that the hoof stresses associated with weight bearing actually facilitate meniscal healing. So this is the evidence proposed, this kind of concept, why weight bearing would be great for the healing process in injury. And also the no clinical evidence to support the limiting weight bearing or knee exercise or knee range of motion exercise restriction in nowadays. So it is still we cannot summarize yet. So, but however, if you believe in accelerated rehab program, anyway, you need to as physical therapy is the one profession in the sport medicine team or the healthcare profession team. When you plan the rehabilitation, you need to work closely or have the close communication with the surgeon as well. Sometimes the surgeon who are the one see inside the knee or who see inside the tissue quality. So maybe that is something need to really carefully in the rehabilitation. So I think it would be better or it would be perfect if you guys like communicate to each other and prescribe the intervention after communication. That would be perfect because we need to take responsibility as a team. Okay, so and the accelerated rehab program, the concept is we believe or we based on the increased tissue stretch, or we expect to have the hypertrophy or the tissue, injured tissue have adaptation after injury. Okay, and the rehabilitation concept, we need to provide the loading because we want the tissue have adaptation to get stronger and to get ready to perform the exercise or return to play in the future, not just finish the healing, but have a risk of recurrent injury. So that's why we need to provide the load, okay? And this is the concept, like provide the load for make the tissue get ready to increase the capacity of the sport activity in the future. And based on the evidence, they already proposed that meniscus tissue, it will be stimulated by the compressive loading, but however, but positive is still question mark, but negative, if we provide the mobilization in the long term, it would create disuse atrophy, and this would be the one factor to increase the risk of injury in the future. But however, in physical therapy program, we need to, our practice should rely on the concept of optimal loading. So optimal loading, that means you need to provide appropriate load without any further injury. So, and this is the guideline of the medical repair in 2017. So this is the goal of the rehabilitation. We need to provide individualization, accelerated rehab character, and also avoid deteriorations. So we also provide the pre-operative management after surgery here. You need to work closely with the surgeon. We need to work closely with the surgeon and also plan ahead to progress the exercise or the rehab based on the performance base, not just based on the time base. So this is the one critical point that I would to mark to mention or to remind you guys. And also, and the research, mostly the mean of return to play, it's range from 4 to 6 months, and also the successful rate or the return to play rate range from like 80 to 90 in some study, but mostly they study in 2 years after in 2 years follow-up. Okay. So as I mentioned, when we prescribe the intervention or rehabilitation, we need to concern in many factors, including location of the injury size, tear type, tissue quality. So you need to talk with the surgeon who see inside the knee and meniscus tissue, and also the patient and therapist adherent to the rehab protocol progression, concomitant injury. Is there any more than one injury or not, any ACL or any other kind of tissue injury, and how the surgical techniques. And the last one, in my opinion, we need to think about patient expectation to return to pre-injury performance related time issue, because some athletes need very quick time to return back to the sport. So that's all my talking today. So this is my faculty. Where am I? The Faculty of Physical Therapy from Mahidol University. Yeah, thank you very much. This is all my presentations. So,
Okay, thank you so much for Mr. Komsak for the presentation. There is one question from anonymous attendee. The question is, hello, as it was stated before from the article from 2017 about accelerated rehabilitation regarding weight bearing and motion 19 degree. Is there any limitation, maybe based on age, BMI, or sex, or can it be applied to all people?
yes, I think, as I mentioned, when we prescribe or when we think about the rehabilitation, we should tailor individually for our patient. But when we interpret from the evidence, the result can guide our rehab. But we need to mix the research result and think about, is it appropriate for our patient as well. But and it's correct as you said, that we need to consider about the age, BMI, and also the sex as well. But sex is not quite sure. But I think for the age, as we know that in the teenage or adult, the tissue quality, it would be like take less time for recovery when compared with the in the elderly or in the case of more age, I think. So hopefully I answered your question.
Okay, thank you very much for the answer. And thank you very much for Asian Komsak for amazing presentation today. Okay, glad to see you.
Yeah, thank you.
Nice to meet you. Sawadika. Okay, for the fifth, terima kasih. Okay, for the fifth speaker is Dr. Muri Kuswari, SPDM, with the theme New Strategies in Sport Nutrition to Increase Exercise Performance. Hello, Mr. Muri. Hello. Okay. At this session, we will discuss about sport nutrition. Okay, for shortening the time, dear Mr. Muri, time is yours.
Okay, thank you very much. First of all, I would like to thank Pak Suryo, Physiotherapy, Departemen Universitas Muhammadiyah Surakarta, and all the committee
Kenceng banget
for
ke-disturb.
inviting me to this
Apa tadi bacanya nggak sadar tahu baca.
conference, and then all speakers and audience. This topic is new on nutrition, but not a lot of nutritionists concerned about this topic. So I hope after this section, many audience interesting about this topic. Okay, the first, in general, when we're talking about the effect of injury athlete, the direct cost and injury is determined by calculating the expense of the using healthcare service to avoid diagnose, treat injury, and it is complication. So when we're talking about injury, we're talking about health-related costs in excess $1 billion worldwide. And then football clubs suffer significant loss many of when players get injured. This is the data of injuries athlete, 52 weeks prospective analysis in elite adolescent athlete found that the prevalence of 1 year injury rate was 91.6%. This is quite a lot, yeah. And the overall rate of the injury was 4.1 for every 1,000 hours of sports exposure, and then average 3 out of 10 or 30% elite energy athletes report injuries per week. The annual cost of sport injury in patient visiting emergency department in Netherlands was 413 million euros every year. This is common problem. The first one is muscle atrophy. This is related with material from Professor Komsak Sinsurin. Yeah. When muscle atrophy, immobilization, this is lead the muscle tissue atrophy at the rate 0.5% per day, accompanied by 50% decline in muscle protein synthesis. Muscle loss can be equal 150 to 400 grams of muscle tissue from a leg with the early stage, 1 to 2 weeks. And then inflammatory, you can see muscle atrophy etiology is multifactorial and can be partly attributed to acute inflammatory and hormonal response. Calcium loss during misuse, bone calcium loss for metabolic rate is decreased, and then insulin sensitivity decline, and then when fat deposit increase. This is inactive period when can also lead to systemic inflammation, insulin resistance, reduction in activation, and recruitment of satellite cell and decrease capillary density, result in lost muscle mass and strength. This is a nutrition part. Nutrition recommendation for reducing surgical complication is to minimizing muscle loss during immobilization and maximizing return to play. And then when injured, after injury or surgery, this is the critical time to improve athlete eating attitudes and then behavior, which lead toward the healing process and enhance performance afterward. Injury and surgery require a long period immobilization involving avoidant muscle contraction, weight bearing initial phase about 6 weeks, and then leads to muscle tissue atrophy rate when we talking about during period rapid muscle strength loss. This is 8% quadricep muscle loss can induce 23% decline in muscle strength. You can imagine if some athlete get injured, many strength loss, and then many muscle mass loss. This is the concern in injury and mobilization. Addressed with the nutrition target, it is elevate caloric demand, increase protein, glucose regulation with complex carbohydrate, and essential fatty acid should be considered. In addition, based on evidence, specific dietary supplement may mitigate the negative effect of surgery and immobilization and support faster healing. Rehabilitation nutrition is quite a new concept for injury treatment. This is only few journals explaining about this. So this is our opportunity to explore more the concept. The concept of rehabilitation nutrition is during rehabilitation and then after injury or surgery. During rehabilitation, the primary goal is to achieve the faster healing and to return competition using the most effective source where nutrition is important component. And then after injury or surgery, it is critical time to improve athlete eating attitude and behavior. I mentioned again, after injury and surgery, this is critical time to improve athlete eating attitude and behavior, which lead toward healing process and enhance performance afterward. This is nutrition needs divided into 3. The first one is energy. Adequate energy intake should be the first nutrition consideration, as negative energy balance accelerates muscle loss, especially in tissue or in mobility period. And macronutrient, it is focused on the function of energy production, hemoglobin synthesis, lean and body mass maintenance, immunity, health, and protection against oxidative damage. And then the micronutrient is supplements such as include branched chain amino acids or BCAA, leucine, and then SMB or leucine enhanced meal are recommended during recovery, especially on early stage of injury. Okay, I will explain. The first one is energy. This is to be used for muscle protein synthesis. This is very important for the athlete, for performance, or for injured athlete. The first nutrition consideration is negative energy balance accelerates muscle loss, especially in tissue in mobility periods. So please, for the athlete, don't not enough consume energy when the injured. And then additionally, an overall reduction energy intake also leads to decline in dietary protein to an amount that failed to meet recommended intake for muscle mass and maintenance in athletes. Energy intake should be higher than the energy target in order to fight sarcopenia. This is 25 to 30 calorie per kilogram of body weight. So you can count your body weight, and then you can compare with 25 to 30 kilocalorie for your energy. Providing excess energy does not further end muscle loss, but rather result in increased fat deposit. And then energy restriction or suddenly inactive as a result of surgery or injury, elevating protein intake to 2.0 or 2 gram per kilogram per day, or even higher may be advantage in free fat mass loss. This is how to calculate your energy expenditure. So this is the first one is Harris Benedict. You can see this. We need kilogram of body weight, and then we need highest of our body, and then our age for men and for women. But if you have free fat mass data, you can use Cunningham with this identifying energy needs during injury and rehabilitation is key first step. Okay, this is the first step to metabolic needs increase to account for basic metabolism and increase energy demand on wood injury healing. You can look at this activity level: sedentary, lightly active, moderately, and very active, and extra active. And then stress factor, you can see this minor injury, minor surgery, and then several burn. Maybe you can count for yourself for this calculation for your energy expenditure. This is personalized nutrition need. This is quite new in nutrition, because personalized nutrition and individualized is not popular in Indonesia, but we straightforward to there. Energy need and quality of calories should be evaluated post-surgery and during recovery. A diet consisting of complex carbohydrate, high-quality protein, and high-quality fats is advised. For example, create a plan with 30 gram serving of complete protein paired with a complex whole grain. This is a strategy to improve the injury. Then the fresh fruit and vegetables, variety of color to help provide antioxidant to enhance recovery, control inflammatory, and provide important micronutrients. This is the key role of protein. Milk-based protein after resistant exercise act favorably on body composition and muscle strength. A higher protein intake is related to muscle mass retention. Excess protein and metabolically difficult to be turned into fat when there is no excess energy intake. One more, excess protein is metabolically difficult to be turned into fat when there is no excess energy intake. When protein extras have continuous amino acid content in this approximate proportion with the found in skeletal muscle. Protein quantity seems to be more important than the type of protein, as no significant difference were found in muscle mass or strength under resistance training when the threshold of 2 grams of leucine was reached and amount of the achieved 20 to 30 of high quality of protein. Far more important that in energy deficit in health distributes in aging, inflammatory, sickness, and higher dose of protein is advised to maximize protein synthesis, whereas a lower dose efficient for well-trained athlete. Considering 2 to 4 hours acceleration window of protein allowed by each meal consumed, the feeding strategy is also an important factor that affects muscle synthesis. During the long period of the day, 12 hours, through postprandial protein excretion, the maximal protein anabolism could be achieved through the increase of meal frequency combined with adequate and eventually protein amount across all meal. 24 hours, muscle synthesis rate was 25% more effective in healthy women and men when the feed with protein evenly distributed across breakfast, lunch, and dinner. So important to you to get your protein at your breakfast, lunch, and dinner to effective muscle protein synthesis for 25%. And then important to avoid low protein breakfast, snack, or dinner, high protein lunch. Protein intake 1.3 to 1.8 gram per kilogram body weight. And then the higher is 1.6 to 2.5 gram per kilogram. So you can consume 20 to 35 gram amount content of height of leucine. And then suggest 4 to 6 meal hike in protein for athletes during resistance training, and then 20 gram of whey protein consumed every 3 hours. This is the role of protein. And then BCAA, this is the mainly leucine play for stimulation of muscle protein synthesis. And then for injured athlete, require 25 to 40 gram of protein intake. And then during recovery from injury, maintain adequate protein intake. And then the type of protein is important. And then 20 gram of whey protein consumed every 3 hours. It is superior for the recovery. And then 1.6 and 2.5 gram per kilogram evenly across of the day is important for the athlete. This is nutrition timing. This is another new in nutrition treatment for the injury athlete. This is the timing of macronutrient engage the day of particularly important with specific attention to nutrition before and after therapy. You can see this for the breakfast, 30 gram of protein, and then morning snack, 20 gram, lunch, 30 gram, and then rehab, before and after rehab, and then dinner, and then before bed. This is meal the required for the meal 3 to 4 hours pre-rehab, and then immediately before rehab, 15 to 45%, 30 gram carbohydrate, and then 25 whey protein, and then creatine monohydrate, and etc. And then after the rehab, immediately post the rehab within 30 minutes, it is 20 gram of whey protein, and then 5 to 10 gram of creatine monohydrate, and then 1.5 gram HMB. Okay, this is the role of carbohydrate. Carbohydrate are the key source of energy during rehabilitation. Low level of carbohydrate influence protein degradation, so increase protein muscle breakdown and reduce the net protein balance, especially in condition of low muscle glycogen compared with high glycogen availability. Despite limited evidence, carbohydrate or unfatty acid benefit compared with protein intake. Balanced diet include adequate amount of protein, carbohydrate, antioxidant, and then moderate fat recommended for rehabilitation and injured athlete. This is the role of fat. We have 2 points. The first one is fish oil, and then the omega-3. This is supplement micronutrients, the leucine and hydroxyl metaborate, and lysine, and then omega-3. And then the vitamin for the injured athlete is vitamin A, had positive effect on wound healing in even non-deficient state. And then the vitamin C is beneficial in patients with several stress or injury. And then the vitamin E decrease in oxidative stress. This is the vitamin required for healing and for the recovery. Vitamin C, vitamin A, and vitamin E. I remember maybe 6 years ago, I talked about ACL injured. No evidence or no guideline for the amount of the vitamin C, vitamin A, vitamin E, and then the many micronutrients. But now 2020, 2021, 2022, we have a lot of journals to explore more about how much we can consume to improve our injury. This is the summary of my presentation. The first one is nutrition play essential role in injured for recovery and rehabilitation. The second one is nutrition recommendation for reducing surgical complication, minimizing muscle loss during immobilization, and maximizing return to play. And then calorie requirements should be identified. So you can see how to count your caloric requirement, and then higher protein intake with a special attention. Let's start collaboration and make an Avenger team, because nutrition and physiotherapy can collaboration for the performance athlete. This is disclaimer. This is our book from 2020 to 2022. The first one is periodisasi gizi dan latihan. The second one is panduan pendampingan gizi pada atlet. The buku pintar gizi bagi atlet, and then the current book with official book for Indonesia Ministry of Health is panduan penyelenggaraan makanan olahragawan. I will share 2 books, panduan pendampingan atlet, and then buku pintar gizi bagi atlet to all of the audience. This is nutrition periodization for the athlete, how we manage when the preparatory phase, competition phase, and then transition phase. When we're talking about preparation, we're talking about carbohydrate types and frequency. And when we're talking about competition, we're talking about carbohydrate control. Post-work nutrition, it is very important because protein, carbohydrate, this is individualized and precision to make recovery athlete is maximum. This is key macronutrient guidelines for the athlete: oxidative stress, and then beneficial of fats, multivitamin use, variety, and then sharing nutrition plans. This is principles to nutrition for the athlete. Every 2 to 4 hours consume, and then it complete lean protein to its feeding opportunity, and then its vegetable to its feeding opportunity. For fat loss, eat carbohydrate other than fruit and vegetables only after exercise, and then all healthy fat daily. This is intensity. This is from our book. I will share after this session. Intensity plate. This is when you doing training for low intensity. You can see this. This is for carbohydrate, protein, and then this is for fruit and vegetable. For the moderate intensity, you can see the carbohydrate bigger, and then protein is same portion, and then the vegetables and then fruit is still. And then this is for hard intensity. You can see double for carbohydrate, double for protein, and then carbohydrate, vegetable and fruit is still same portion. This is from our new book 2022. This is how we prepare nutrition timing for when the start, when the match or competition or training start at 10 p.m. This is for breakfast, and then for snacking, and then etc. This is for afternoon training at 2 p.m. You can see this is for 5 p.m. training, and then this is for 7 p.m. training. I think that's all. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Okay, thank you very much for Dr. Murari, SPD, MSE. To the participant, if you have any question, please leave your question on the Q&A box. Okay. Dr. Muri, there is a question. What the best after meniscus surgery?
Okay, when we talking about meniscus surgery, we're talking about protein is very important because can help to healing, and then maintain your muscle mass and muscle strength in face of immobility, and then enough of 10 to 20 gram of carbohydrate, and then 2.5 gram per kilogram body weight of protein 4 times a day. I think this is for the answer from me. Thank you.
Okay, thank you so much for the answer, Dr. Murikoswari. If there are any question, please leave your question on Q&A box. Okay, there is another question from the participant. The question is it okay for athletes to eat gorengan?
Not people ya, but if you eat some gorengan, this is only for make your happy, make your relax maybe, because we know some athletes have superfood is gorengan or chocolate or soda, but it's only for make relax before game. So the amount of the gorengan is very important. The important thing is the athlete is not a patient or a sick people. Okay, I think this is my question, my answer.
Okay, thank you very much for Dr. Murikoswari SPDMSE for your coming today. Have a nice day. See you later.
Thank you.
Thank you so much. Okay, now time to break a while. We will back again here at 12:45 p.m. with our last speaker, Mr. Wijianto.
Iqbal, ada ruang. Kalian nunggu siapa? Untuk boy, baik sekali. Oh, masuk. Coba. Kesempatan. Akhirnya. Buka. Iqbal lagi. Iqbal, kita lihat. Dengan sontekan kaki kirinya Iqbal.
maksimal, tambah lagi. Terus, dan terus maksimal, tambah lagi. Terus, relax, keluar, maksimal terus.
Surakarta, the spirit of Java, merupakan kota terbesar kedua di Jawa Tengah dengan daya tarik kearifan budaya dan pendidikan yang semakin dalam. Di Surakarta, terdapat Universitas Muhammadiyah Surakarta yang berakreditasi unggul oleh Badan Akreditasi Nasional Perguruan Tinggi pada tahun 2021 hingga pada tahun 2026. Salah satu program pendidikan yang terdapat di Universitas Muhammadiyah Surakarta adalah Fisioterapi S1 yang berakreditasi A atau Excellent dan profesi fisioterapi berakreditasi B oleh Perkumpulan Lembaga Akreditasi Mandiri Pendidikan Tinggi Kesehatan Indonesia atau LAMKES. Fisioterapi UMS bervisi pada tahun 2029 menjadi pusat unggulan dan inovasi IPTEX yang islami di bidang fisioterapi melalui budaya akademik yang kuat, pelayanan kesehatan serta kemitraan yang berorientasi pada fisioterapi komunitas pada lingkup nasional dan global. Fisioterapi UMS bekerja sama dengan berbagai instansi kesehatan dan pendidikan seperti Mahidol University Thailand, Konkan University Thailand, University Teknologi Mara Malaysia, Rumah Sakit Umum Pusat Dr. Karya di Semarang, Rumah Sakit Ortopedi Profesor Dr. Rajiman Suharso Surakarta, Rumah Sakit Umum Pusat atau RSUP Dr. Sarjito Yogyakarta, serta perusahaan Physiotherapy. Fisioterapi UMS memiliki fasilitas gedung Auditorium Kiai Haji Ahmad Dahlan, Masjid Haji Sudalmiah Rais, ruang kelas, ruangan laboratorium, serta memiliki komunitas difabel dan desa binaan.
السلام عليكم ورحمة الله وبركاته. أنا عاصم عبد الله أحمد عبده من اليمن. أنا طالب دولي في الجامعة المحمدية سوراكارتا، أدرس في قسم العلاج الطبيعي. أنا سعيد جدا لاختياري الجامعة المحمدية سوراكارتا كونها من أفضل الجامعات في إندونيسيا، وهناك أيضا كادر تعليمي ممتاز في قسم العلاج الطبيعي ومحاضرات جيدة للغاية. أنا سعيد جدا لاختياري هذه الجامعة حقا، والسلام عليكم ورحمة الله وبركاته. شكرا جزيلا.
Selama kuliah di UMS, saya merasa sangat senang karena saya rasa dosen-dosen di sini sudah sangat profesional dalam mendidik mahasiswanya. Selain itu juga fasilitas-fasilitas yang ada sudah sangat lengkap sehingga memudahkan kami sebagai mahasiswa untuk praktek secara langsung di dalam kelas.
Fisioterapi UMS memiliki dosen berprestasi yaitu Suryo Saputra Perdana MSc, PT, Dwi Rosela Komalasari PhD, PT, Dr. Umi Budi Rahayu MKes, dan juga Tiara Fatmariska MSc IH. Berbagai prestasi yang diraih mahasiswa antara lain Surakarta, The Spirit of Java, merupakan kota terbesar kedua di Jawa Tengah dengan daya tarik kearifan budaya dan pendidikan yang semakin dalam. Di Surakarta, terdapat Universitas Muhammadiyah Surakarta yang berakreditasi unggul oleh Badan Akreditasi Nasional Perguruan Tinggi pada tahun 2021 hingga pada tahun 2026. Salah satu program pendidikan yang terdapat di Universitas Muhammadiyah Surakarta adalah Fisioterapi S1 yang berakreditasi A atau Excellent dan profesi fisioterapi berakreditasi B oleh Perkumpulan Lembaga Akreditasi Mandiri Pendidikan Tinggi Kesehatan Indonesia atau LAMKES. Fisioterapi UMS bervisi pada tahun 2029 menjadi pusat unggulan dan inovasi iptek yang islami di bidang fisioterapi melalui budaya akademik yang kuat, pelayanan kesehatan serta kemitraan yang berorientasi pada fisioterapi komunitas pada lingkup nasional dan global.
Fisioterapi UMS bekerja sama dengan berbagai instansi kesehatan dan pendidikan seperti Mahidol University Thailand, Konkan University Thailand, University Teknologi Mara Malaysia, Rumah Sakit Umum Pusat Dr. Karya di Semarang, Rumah Sakit Ortopedi Profesor Dr. Rajiman Suharso Surakarta, Rumah Sakit Umum Pusat atau RSUP Dr. Sarjito Yogyakarta, serta perusahaan Physiotherapy.
Fisioterapi UMS memiliki fasilitas gedung Auditorium Kiai Haji Ahmad Dahlan, Masjid Haji Sudalmiah Rais, ruang kelas, ruangan laboratorium, serta memiliki komunitas difabel dan desa binaan.
Assalamualaikum warahmatullahi wabarakatuh. Ana Asim Abdullah Ahmed Abdo من اليمن. أنا طالب دولي في الجامعة المحمدية سوراكارتا، أدرس في قسم العلاج الطبيعي. أنا سعيد جدا لاختياري الجامعة المحمدية سوراكارتا كونها من أفضل الجامعات في إندونيسيا، وهناك أيضا كادر تعليمي ممتاز في قسم العلاج الطبيعي ومحاضرات جيدة للغاية. أنا سعيد جدا لاختياري هذه الجامعة حقا. Wassalamualaikum warahmatullahi wabarakatuh. Syukran jaziran.
Selama kuliah di UMS, saya merasa sangat senang karena saya rasa dosen-dosen di sini sudah sangat profesional dalam mendidik mahasiswanya. Selain itu juga fasilitas-fasilitas yang ada sudah sangat lengkap sehingga memudahkan kami sebagai mahasiswa untuk praktek secara langsung di dalam kelas.
Fisioterapi UMS memiliki dosen berprestasi yaitu Suryo Saputra Perdana MSc, PT, Dwi Rosela Komalasari PhD, PT, Dr. Umi Budi Rahayu MKes, dan juga Tiara Fatmariska MSc IH. Berbagai prestasi yang diraih mahasiswa antara lain Surakarta, The Spirit of Java, merupakan kota terbesar kedua di Jawa Tengah dengan daya tarik kearifan budaya dan pendidikan yang semakin dalam. Di Surakarta, terdapat Universitas Muhammadiyah Surakarta yang berakreditasi unggul oleh Badan Akreditasi Nasional Perguruan Tinggi pada tahun 2021 hingga pada tahun 2026. Salah satu program pendidikan yang terdapat di Universitas Muhammadiyah Surakarta adalah Fisioterapi S1 yang berakreditasi A atau Excellent dan profesi fisioterapi berakreditasi B oleh Perkumpulan Lembaga Akreditasi Mandiri Pendidikan Tinggi Kesehatan Indonesia atau LAMKES. Fisioterapi UMS bervisi pada tahun 2029 menjadi pusat unggulan dan inovasi IPTEX yang islami di bidang fisioterapi melalui budaya akademik yang kuat, pelayanan kesehatan serta kemitraan yang berorientasi pada fisioterapi komunitas pada lingkup nasional dan global.
Fisioterapi UMS bekerja sama dengan berbagai instansi kesehatan dan pendidikan seperti Mahidol University Thailand, Konkan University Thailand, University Teknologi Mara Malaysia, Rumah Sakit Umum Pusat Dr. Karya di Semarang, Rumah Sakit Ortopedi Profesor Dr. Rajiman Suharso Surakarta, Rumah Sakit Umum Pusat atau RSUP Dr. Sarjito Yogyakarta, serta perusahaan Physiotherapy.
Fisioterapi UMS memiliki fasilitas gedung Auditorium Kiai Haji Ahmad Dahlan, Masjid Haji Sudalmiah Rais, ruang kelas, ruangan laboratorium, serta memiliki komunitas difabel dan desa binaan.
Assalamualaikum warahmatullahi wabarakatuh. أنا عاصم عبد الله أحمد عبده من اليمن. أنا طالب دولي في الجامعة المحمدية سوراكارتا، أدرس في قسم العلاج الطبيعي. أنا سعيد جدا لاختياري الجامعة المحمدية سوراكارتا كونها من أفضل الجامعات في إندونيسيا، وهناك أيضا كادر تعليمي ممتاز في قسم العلاج الطبيعي ومحاضرات جيدة للغاية. أنا سعيد جدا لاختياري هذه الجامعة حقا. والسلام عليكم ورحمة الله وبركاته. شكرا جزيلا.
Selama kuliah di UMS, saya merasa sangat senang karena saya rasa dosen-dosen di sini sudah sangat profesional dalam mendidik mahasiswanya. Selain itu juga fasilitas-fasilitas yang ada sudah sangat lengkap sehingga memudahkan kami sebagai mahasiswa untuk praktek secara langsung di dalam kelas.
Fisioterapi UMS memiliki dosen berprestasi yaitu Suryo Saputra Perdana MSc, PT, Dwi Rosela Komalasari PhD, PT, Dr. Umi Budi Rahayu MKes, dan juga Tiara Fatmariska MSc IH. Berbagai prestasi yang diraih mahasiswa antara lain
baik untuk mengoptimalkan gangguan gerak dan fungsi sebagai makhluk biopsikososial. Melaksanakan penelitian dengan kemampuan literasi yang sesuai dengan perkembangan ilmu pengetahuan dan teknologi di bidang fisioterapi. Melaksanakan kegiatan pengabdian kepada masyarakat melalui komunikasi, informasi, edukasi, dan pelayanan yang baik. Pada proses belajar mengajar di Prodi Profesi Fisioterapi, ini ditempuh selama 3 semester, di mana nanti mahasiswa akan praktek di beberapa rumah sakit negeri, rumah sakit swasta maupun amal usaha Muhammadiyah, serta lahan komunitas. Kami berharap semoga prodi ini dapat menjadi salah satu prodi yang menghasilkan generasi penerus bangsa yang cerdas, giat bekerja dengan penuh integritas, sehingga mampu menjadi rahmatan lil alamin bagi alam semesta ini. Amin.
Halo semuanya,
saya Hani.
saya Kurnia.
Kita dari mahasiswa Profesi Fisioterapi Angkatan 6 Universitas Muhammadiyah Surakarta.
Kita sedang menempuh pendidikan profesi fisioterapi di Rumah Sakit Paru Dr. Ari Wirawan Salatiga.
Tentunya selama kita menempuh pendidikan profesi ini, sangat banyak ilmu dan pengetahuan yang kita dapatkan seputar ilmu klinis fisioterapi dengan berbagai stase, yaitu stase pediatri,
Muskuloskeletal,
geriatri, dan masih banyak lagi.
Selama menempuh pendidikan profesi fisioterapi, kita belajar tentang pelayanan fisioterapi, komunikasi yang baik kepada pasien, manajemen klinik, dan etika kita sebagai tenaga kesehatan.
Kita berharap dengan lulusan profesi fisioterapi ini menjadikan lulusan fisioterapi yang unggul dan menjadikan fisioterapi yang berkemajuan.
Assalamualaikum warahmatullahi wabarakatuh. Perkenalkan, saya Kinginarti FTR. Saya bekerja di RSUD Dr. Harjono Ponorogo, dan kalau sore saya membuka praktek fisioterapi mandiri di Kota Ponorogo. Saya adalah salah satu lulusan dari Universitas Muhammadiyah Surakarta. Alhamdulillah, saya bangga sebagai lulusan program studi profesi fisioterapi, di mana prodi ini mempunyai fasilitas perkuliahan yang lengkap seperti laboratorium praktek yang memadai dan tenaga pengajar yang berkompeten di bidang fisioterapi, serta semangat dan perjuangan rekan-rekan seangkatan yang selalu memberikan support, dorongan, dan dukungan doa, sehingga kami semua bisa meraih cita-cita kami, yakni mendapatkan gelar FTR. Saya bangga sebagai alumni UMS dan saya bangga sebagai lulusan program studi fisioterapi UMS. Wassalamualaikum warahmatullahi wabarakatuh.
Jadi tunggu apa lagi? Yuk join di profesi fisioterapi Universitas Muhammadiyah Surakarta sekarang. Wassalamualaikum warahmatullahi wabarakatuh. Dadah.
Assalamualaikum warahmatullahi wabarakatuh. Pertama-tama kami panjatkan puji syukur kehadirat Allah Subhanahu wa Ta'ala karena atas rahmat dan karunia-Nya lah program studi pendidikan profesi fisioterapis Universitas Muhammadiyah Surakarta mampu memberikan kontribusi bagi bangsa dan negara Indonesia. Prodi profesi fisioterapis ini dengan bangga menghasilkan lulusan yang mampu memberikan solusi komprehensif bagi permasalahan-permasalahan klinis terkait dengan kondisi yang ada di rumah sakit, klinik, serta lahan komunitas. Program studi ini sudah terakreditasi B dengan visi misi sebagai berikut. Visi pada tahun 2029 menjadi pusat unggulan dan inovasi iptek yang islami di bidang profesi fisioterapis melalui budaya akademik yang kuat, pelayanan kesehatan, serta kemitraan yang berorientasi pada fisioterapi komunitas pada lingkungan nasional dan global. Misi menyelenggarakan pendidikan profesi fisioterapi yang islami, inovatif, dan profesional, serta terampil dalam penalaran klinis berdasarkan bukti ilmiah yang terbaik untuk mengoptimalkan gangguan gerak dan fungsi sebagai makhluk biopsikososial. Melaksanakan penelitian dengan kemampuan literasi yang sesuai dengan perkembangan ilmu pengetahuan dan teknologi di bidang fisioterapi. Melaksanakan kegiatan pengabdian kepada masyarakat melalui komunikasi, informasi, edukasi, dan pelayanan yang baik. Pada proses belajar mengajar di prodi profesi fisioterapi ini ditempuh selama 3 semester, di mana nanti mahasiswa akan praktek di beberapa rumah sakit negeri, rumah sakit swasta maupun amal usaha Muhammadiyah serta lahan komunitas. Kami berharap semoga prodi ini dapat menjadi salah satu prodi yang menghasilkan generasi penerus bangsa yang cerdas, giat bekerja dengan penuh integritas sehingga mampu menjadi rahmatan lil alamin bagi alam semesta ini. Amin.
Halo semuanya,
Saya Hani.
saya Kurnia.
Kita dari mahasiswa profesi fisioterapi angkatan 6 Universitas Muhammadiyah Surakarta.
Kita sedang menempuh pendidikan profesi fisioterapi di Rumah Sakit Paru Dr. Ari Wirawan Salatiga.
Tentunya selama kita menempuh pendidikan profesi ini, sangat banyak ilmu dan pengetahuan yang kita dapatkan seputar ilmu klinis fisioterapi dengan berbagai stase, yaitu stase pediatri,
muskuloskeletal,
geriatri, dan masih banyak lagi.
Selama menempuh pendidikan profesi fisioterapi, kita belajar tentang pelayanan fisioterapi, komunikasi yang baik kepada pasien, manajemen klinik, dan etika kita sebagai tenaga kesehatan.
Kita berharap dengan lulusan profesi fisioterapi ini menjadikan lulusan fisioterapi yang unggul dan menjadikan fisioterapi yang berkemajuan.
Assalamualaikum warahmatullahi wabarakatuh. Perkenalkan, saya Kinginarti FKR. Saya bekerja di RSUD Dr. Harjono Ponorogo dan kalau sore saya membuka praktek fisioterapi mandiri di Kota Ponorogo. Saya adalah salah satu lulusan dari Universitas Muhammadiyah Surakarta. Alhamdulillah, saya bangga sebagai lulusan program studi profesi fisioterapi, di mana prodi ini mempunyai fasilitas perkuliahan yang lengkap seperti laboratorium praktek yang memadai dan tenaga pengajar yang berkompeten di bidang fisioterapi, serta semangat dan perjuangan rekan-rekan seangkatan yang selalu memberikan support, dorongan, dan dukungan doa sehingga kami semua bisa meraih cita-cita kami, yakni mendapatkan gelar FTR. Saya bangga sebagai alumni UMS dan saya bangga sebagai lulusan program studi fisioterapi UMS. Wassalamualaikum warahmatullahi wabarakatuh.
tunggu apa lagi? Yuk join di profesi fisioterapi Universitas Muhammadiyah Surakarta sekarang. Wassalamualaikum warahmatullahi wabarakatuh. Dadah.
Pertama-tama saya terima kasih sama tidak ini saya sudah bergabung kepada saya untuk melakukan di sini. Saya lagi pasca operasi, jadi saya memang membutuhkan untuk tes seperti ini. Bagi Anda yang suka dengan olahraga, seorang atlet, seorang sepak bola juga seperti saya sarankan untuk mencoba di tempat ini karena bisa membantu para korban terbaik.
Oke, dari semua alat ini apa yang paling menyenangkan atau hal apa yang didapatkan dari masa ini?
Kalau saya sih, saya nggak tahu namanya lebih yang
oke, ini first deck.
Ya, karena kalau saya ini kan dia lebih ke posisi yang sempurna di apa ya ketika kita main bola. Sempurna lebih bagus untuk meminimalisir cedera menurut saya sih gitu. Kalau alat yang lain kan mungkin bisa pakai umum, bisa pakai alat ataupun kan bisa disalahkan di rumah atau di tempat yang lain. Tapi kalau ini mungkin bisa digunakan di sini.
Oke. Terima kasih banyak Mas Budi.
Sudah siap.
Okay, welcome back to the conference. Thank you so much for staying with us. Now we can start again the conference with the last but not least speaker. Is Mr. Wijianto, SST, FT, FTR, MOR. IFO with the theme Development through Sport based on Community Development. Hello, Mr. Wijianto. Good afternoon, Mr. Wijianto. How are you today, Mr.?
I am fine.
Okay, thank you so much. Before Mr. Wijianto start the presentation, I'll remind for all the participants. If you have any question, feel free to put your question in Q&A box. Okay, the next is, are you ready, Mr. Wijianto?
Yes.
Okay. For Mr. Wijianto, time is yours.
Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. But firstly, I thank you very much to the speaker at the 2022 ABC event. Hopefully, what has been completed and is useful for all of us. I mean, not forget, I also thanks all the participants who were present in this activity. Next one. Community in this topic presentation. Okay, next. Component of sport community among is athletes, sport, media, funds, coach of manager, and sport organization, where each component is really has the role support each other and contribute to each other so that a good sport community will be created for development of the sport world. Social health is the ability to develop and maintain close relationship with others, respect for others, and tolerance for different opinion and belief. In an organization of our team, it is very important to have mutually beneficial cooperation and support toward progress. As well as in this community sport, there are several aspects to support each other. Sport community health meaning among other, its relationship with athletes is about strengthening its other among other and giving and receiving support among family and friends to improve their ability to achieve the desired goal. For example, in this athletic sport, to achieve an achievement, there are several aspects involved, including the athletes themselves, their families, coach, and experimental practitioners. Athletes said to decay to success in both the world of sport and business. Better communication from the coach will have a positive impact on our performance. Poor communication is responsible for declining performance in the in the business world. Sport in media. A component of sport media, how the role of the media affect the sport itself and was as well as team and individual. Media include all form of aspect sport promotion such as TV and radio showing or commenting on matches and competition. They also highlight live documentaries and quiz show about sport. The role is extraordinary in the development of the world of sport, both the foster interest in viewing and providing support or business. Media. Di sini ada aspek internet, major team and athletic have their own website which will find all kinds of information about teams, athletes, match. Newspaper and magazine, print prediction and results, as well as article about athletic and clubs. Book and movies contain all biographies of former athletes. Positive effect of sport in media. Number one, money. Media companies pay for the right to show sporting events and sport that are shown on TV will generate for sponsors. Number two, education. People will get a sport lesson that what is shown. Number three, inspiration. The media brings sport to people who are usually never involved, then are encouraged to join in it. Number four, training help. Watching professional on TV can help you see how techniques should be performed so that you can have a performance. Negative effect, lack of attendance. Formats so on TV, ticket sales often drop. Overload. There is a lot of sport on TV nowadays. Some say too much attention. Sport stars often complain that too much attention is paid to their personal lives. Demand. The media can put pressure on sport competition organization to create a better viewing experience for TV viewers. Fun. For affect society in many ways, so it is not surprising that there are systematic changes that need to be made to improve sport condition and provide a better reflection of society at large. Sport affect behavior both directly and indirectly. See you for attention. See you again at ABC 2023. Saya kembalikan ke Mbak Aura.
Okay. For all the participant, if you have any question for Mr. Wijianto, please write on the Q&A box. Okay, there is one question for Mr. Wijanto. The question is, what is the first step to develop sport community? Okay, Mr. Wijanto.
Oke.
Please answer.
Saya langsung dengan bahasa Indonesia ya.
Okay. No problem, Mister.
Oke. Tahapan untuk gimana, Mbak? Halo.
Develop. What is the first step to develop sport community?
Oke, terima kasih. Tahapan untuk mengembangkan sport community di sini harus ada sinergi antara atlet, antara organisasi olahraga, antara fund, antara media ya, dan pelatih ya. Ini sangat menunjang ya, ada sinergi dalam aktivitas, sinergi dalam kegiatan, dan ini saling akan mendukung untuk tercapainya kondisi sport community yang baik. Kita ambil contoh misalnya atletnya punya karakter yang bagus, semangat latihan bagus, prestasinya bagus, ini akan didukung oleh media yang bagus, maka fan atau penggemar ini juga akan banyak. Kemudian untuk atlet yang punya prestasi yang bagus, karakter attitude yang bagus juga, jadi disupport juga oleh keluarga, disupport juga oleh pelatih dan lain-lainnya, sehingga akan tercipta kondisi yang saling bersinergi untuk menciptakan sport community. Itu, Mbak.
Okay, thank you very much for Mr. Wijanto. The next question is, can you explain about the role of physiotherapy in sport community?
Ya, yang ingin kami jawab ya, pertanyaan yang bagus sekali tadi, bagaimana pengalaman ya, Mbak ya, menjadi sport community ya. Di sini memang kita di sport community ini untuk di Indonesia perlu perjuangan ya untuk menciptakan dan menumbuhkan semangat sport community ini. Ya, pengalaman kita ya, kita memulai dari lingkungan, dimulai dari sekitar kita untuk menciptakan, mengkondisikan sport community yang baik, sehingga nanti setiap ada event, ya, ada kegiatan, terutama kegiatan-kegiatan yang besar itu akan sudah terkondisikan dengan baik dengan komponen-komponen yang ada pada sport community tadi, Mbak. Gitu, Mbak.
Okay, thank you very much, Mr. Wijanto. If there is another question, please write your question at Q&A box. Okay, for Mr. Wijanto, there is another question. The question is, what is the difference sport community and sport clinic?
Oke, terima kasih. Pertanyaan itu bagus ya. Sebenarnya apa sih yang membedakan antara sport community dan sport klinik ya? Di sini memang sport community ini memang lahan yang mau kita kembangkan untuk unggulan fisioterapi profesi kayaknya dengan dunia olahraga ya. Dan sport klinis ini juga sangat istilahnya itu juga sangat berkolaborasi atau bisa menjadi bagian dari sport community. Artinya apa? Kita perlu pengembangan ya sport community yang baik, yang mana di dalamnya itu ada aspek klinis yang nanti bisa kita wujudkan, kita istilahnya itu kita kontribusikan untuk saling mendukung ya. Jadi di sini klinis itu berarti berkaitan dengan praktek atau pelayanan fisioterapi sport community, tapi sport community di sini banyak aspek yang terlibat. Jadi sport klinis itu merupakan bagian dari sport community, gitu Pak. Oke. Kalau di bahasa Jawa, bahasa Indonesianya apa ini?
Bangun komunikasi dengan staf dalam mengembangkan komunitas. Seperti itu, Pak.
Oke, terima kasih. Di sini perlu kita siapkan ya dari ini pertama pertanyaan bagus sekali kayaknya dengan gimana kita membangun mitra, membangun internal kita, staf kita untuk meraih atau menciptakan sport community yang bagus. Di sini perlu kita tekankan bahwa keunggulan kita di fisioterapi profesi adalah komunitas, maka di sini mulai tahun ini ya sport komunitas itu bisa masuk ke beberapa aspek. Artinya apa? Aspek muskuloskeletal kita bisa masuk, aspek neuro kita bisa masuk, aspek respirasi kita bisa masuk, dan aspek sport itu juga bisa masuk. Nah, gimana tahapan-tahapannya untuk menciptakan itu? Maka kita harus memahami konsep fisioterapi komunitas. Kemudian kita harus melakukan suatu proses atau proses asesmen fisioterapi komunitas. Kemudian baru kita bisa menyimpulkan kebutuhan dasar dari komunitas itu. Kemudian baru kita bisa merencanakan tindakan dan kita bisa mengevaluasi tindakan itu sampai ke sasaran atau enggak dari target yang kita tentukan. Jadi di sini pemahaman yang kuat, yang istilahnya yang ideal yang harus kita lakukan, harus kita punya sebelum kita masuk ke sport community maupun komunitas-komunitas yang lain. Itu Mbak.
Thank you very much for Mr. Wijianto for sharing and informative materials today. See you at the next event at Academic Physiotherapy Conference 2023. See you next time, Mr. Wijianto.
Yes.
Have a nice day. Have a nice day.
Yeah. Okay.
Nice day. The next agenda is announcement of the best presenter of call for paper. Congratulations for Ida Fitria for the best presenter of call for paper in Academic Physiotherapy Conference 2022. For the award for the winner, will get free access of VisiTrack for a month. For the appreciation, we would like to invite Kak Ida Fitria to give a statement regarding her achievement for the best presenter of call for paper in Academic Physiotherapy Conference 2022.
Throughout the intervention, and even after the my research has ended, and I need to get information out of him, or if I need confirm something from him, he was really cooperative with that too. And then the second is I'm really thankful for Mr. Agus Widodo for helping me on my writings. And the third is for Mr. Ismadi, physiotherapy at Wonosari General Hospital, because he's really helping me a lot throughout the intervention. And for the last is for my teammate and my friends for the psychological help. And thank you again for the nomination.
Okay, congratulations again for Kak Ida Fitria. Do you want to sharing with us tips and tricks as the best presenter in this?
I don't know how to give like tips and trick. I guess for me personally, you have to like really, like really good at you have to know all of like your papers, your writing. You have to master that first, and then the second, you have to really understanding your case, and then the third, you have to like confident about it. And then if you like have a problem, you have to like can consult it with your lecturer and maybe at your hospital physiotherapist. I guess maybe that's it personally for me.
To all participants, don't forget to fill the attendee form that has been sent at Q&A box below. Okay, I will remind again to all participants. Don't forget to fill the attendee form that has been sent at Q&A box below. Okay, the link of attendee form that will send at the group. And the last agenda is closing. To close the program. Let's recite Alhamdulillahirabbil alamin. Finally, from the deep of my heart, I do apologize for my mistake while in presenting this event. Thank you very much for all speakers and all participants for your attention and joining this event. Wassalamualaikum warahmatullahi wabarakatuh.